welcome everyone to meeting number 32 of the House of Commons Standing Committee on Health. Pursuant to the order of reference of May 26, 2020, the committee is resuming its briefing on the Canadian response to the outbreak of the coronavirus. To ensure an orderly meeting, I would like to outline a few rules to follow. Interpretation in this video conference will work very much like in a regular committee meeting. You have the choice at the bottom of your screen of either Floor, English, or French. As you're speaking, if you plan to alternate from one language to the other, you will need also to switch the interpretation channel so that it aligns with the language you're speaking. You may want also to allow a short pause when switching languages. Before speaking, please wait until you are recognized. And when you're ready to speak, you can click on the microphone icon to activate your mic. A reminder that all comments by members and witnesses should be addressed through the chair. And when you're not speaking, your mic should be on mute. Please note that I will be very strict on time today, given the fact that we have to move in camera later. I would now like to welcome our first panel of witnesses. So appearing as an individual, we have Dr. Arjamand Siddiqui, Associate Professor, Dalla Lana School of Public Health at the University of Toronto. And from the Wellesley Institute, Dr. Kwame Mackenzie, Chief Executive Officer. Welcome to you all. We'll start with Dr. Siddiqui. Please go ahead. You have 10 minutes.
Thank you very much. Thanks for the opportunity to speak with you today. I come here with a deep sense of gratitude for my parents and all the others who have made this possible, a strong sense of responsibility that comes with my position as a scientist, and a burning desire for my country, Canada, to do right by all its people. I am Associate Professor and Division Head of Epidemiology at the University of Toronto's Dalla Lana School of Public Health, where I hold the Canada Research Chair in Population Health Equity. I'm a social epidemiologist, and I study health inequities and the social determinants of health, with a particular emphasis on the social policies and other societal factors that are ultimately responsible for giving everyone a chance at health. Since the gravity of the COVID-19 pandemic became apparent, Canadian officials have assured us that we are all in this together. Indeed, daily briefings have impressed upon us a sense that the overall number of cases and deaths in our cities and provinces are a good proxy for how worried each of us should be about our risk for COVID-19, or how confident we can feel about returning to some of our pre-COVID activities. However, in late May came a stunning report, if entirely predictable by those of us who study these things and those of us who live them, which suggested that the citywide numbers we were receiving in briefings from Toronto Public Health concealed enormous differences in the burden and risk of COVID-19 across Toronto neighborhoods. A similar phenomenon has also been noted for Montreal. Toronto's northwest neighborhoods, which are heavily Black and working class, areas such as Jane and Finch, Rexdale, and Weston, have been hardest hit. The latest figures suggest case rates in excess of 450 per 100,000 in those neighborhoods. Meanwhile, in the downtown core and central areas, which are heavily white and wealthy, these areas have barely been touched. For example, Yonge and Eglinton has a case rate of 14 and Beaches 15 cases per 100,000. This means that the overall figures for Toronto have been obfuscating a more than 40 times greater risk of COVID-19 between Toronto's Black working class neighborhoods compared to its white rich neighborhoods. While the coronavirus itself does not discriminate, our society unfortunately does. Canada is structured in a way that has placed the burden of risk for COVID-19 squarely on the shoulders and in the lungs of the Black working class, and to a lesser extent, other non-white working class people. The spatial distribution of COVID-19 across Toronto neighborhoods is less a reflection of neighborhoods themselves being risky and more a reflection of the fact that the Black people in Toronto tend to live in a small set of neighborhoods, which are the ones in which they can afford housing and avoid housing discrimination, while rich whites live in a set of neighborhoods that offer the most convenience and comfort. Why are we using neighborhood data if neighbors aren't really the heart of the matter? Unfortunately, those are the best data we have available for understanding the social characteristics, race, income, and so on, that carry risk for ill health, including COVID-19. We are effectively using neighborhood characteristics to proxy for individual characteristics. And because Toronto is so starkly and structurally segregated, and people are so clustered by race and income into various neighborhoods, for now, this is sadly a reasonable proxy to make, even if it's imperfect. My initial plea to you then is to think long and hard about better collection of race and socioeconomic data whenever we routinely collect data in Canada on health and other matters in our healthcare system, our schools, the labor market, and so on. This is critical for understanding our country and holding our government to account for racial inequity in the same way gender data is used to tackle gender inequity. So if not the neighborhood itself, what then is creating greater risk for Black working class people? Because the data is lacking, it's difficult to be unequivocal about the answers to this question. However, there is a very large and robust body of research from other countries on which we can draw, as well as indirect evidence from Canada. The strongest candidate explanation, though there are others which I am happy to discuss, is that essential service jobs that have continued during the stay-at-home orders are largely occupied by Black and other non-white working class people. They are our long-term care and personal support workers. They clean our hospitals and shuttle patients around. They stock our grocery stores, drive our delivery trucks, and work in the fields to harvest our produce. Conversely, jobs that afford the opportunity to stay home, and that too with peace of mind about one's job security and income, are largely occupied by wealthy white people. They are our bankers and financiers, lawyers, and yes, our professors. The obvious consequence is that jobs occupied disproportionately by Black and other non-white Canadians force them into environments that carry high risk for exposure to COVID-19, while jobs disproportionately occupied by wealthier whites offer protection from exposure to COVID-19. At the end of the day, knowing that they have little choice, we are sacrificing low-wage Black and other non-white workers so that the rest of us can cocoon in the comforts of our home and wait this thing out. This racial job sorting is clearly not a function of chance or choice. It is the outcome of a confluence of Canadian policies and systems in which racial discrimination is so persistent and pervasive that it cannot be regarded as isolated incident or even as an add-on to understanding our systems and of institutions and policies. Rather, it is an integral part of the systems themselves. Various scholars have used terms such as systemic racism, structural racism, institutional racism, and racial capitalism to refer to this deep embedding of racism in our societal policies and systems. Beyond jobs, systemic racism is more generally the major factor that determines who has economic security, wealth, and income. It can even be more powerful than gender in this respect. In turn, economic security is the main predictor of health because it facilitates the everyday living conditions that are foundational for health. Jobs that don't expose us to health risks, plenty of money to pay the bills, comfortable housing, lovely neighborhoods, good food, and low stress. And this is true whether we're talking about COVID-19 or cardiovascular disease, depression or diabetes. At the end of the day, you need economic security to have a good chance at living a healthy life. And that is precisely why economic security is so crucial. And it is precisely why racial health inequalities are so pervasive and so persistent. Racism limits Black working class people's access to wealth, jobs, income, and so on. As horrible as it is that we have racial inequities in COVID-19, this is really just another manifestation of a deeply entrenched system of racial inequity. So it's the root cause, systemic racism, that we really need to fix in order to address COVID-19 inequities. In what follows, I will outline what the science tells us are our best options for doing so. The first is to deal forcefully with racial wealth inequity in stocks of money and assets. Economists such as Miles Korak in Canada and William Darity Jr. and Derek Hamilton in the United States have made a jarring discovery about wealth inequity, which, as I will explain, is arguably even more critical than income inequality. It turns out that the largest source of racial wealth inequity is not racial differences in education or even in jobs and income. Those things matter, but they are the consequences, not the causes of racial wealth inequity. The biggest source of racial wealth inequity is what economists refer to as intergenerational transfers, and what the rest of us would call gifts from mom and dad and grandma and grandpa. That's right. The white wealth advantage is not an earned advantage. Gifts are what allow whites to pay for advancing their education and thus income, and what allow them to put down payments on homes early in life. This is unfair for many reasons, perhaps the greatest of which is the historic injustices that have allowed whites, but not others, to accumulate wealth over generations. So it is these wealth transfers that create opportunity for income rather than income creating opportunity for wealth. That means that Black Canadians have already fallen behind at birth. This is unacceptable, and Canada must consider, as the United States is, a system of baby bonds or something similar, in which young children from Black and other groups that have historically faced disadvantage are provided a sum which matures as the child ages, and in adulthood can be used in the same way that family gifts have been used by rich white families. Economists have even calculated how long such a policy would take to create wealth equality. In addition to resolving wealth inequity, we do need to address income security for every Canadian. We need to design a labor market in which every job is a high-quality job. We need to ensure the wages, benefits, and working conditions of all jobs meet a high minimum standard and that employment discrimination is more rigorously penalized. We have strong randomized trial data that tells us a very disheartening tale of racial discrimination in the labor market that cannot be accounted for by differences in foreign degrees or lack of Canadian job experience. We have to stop taking comfort in the fact that people are somehow managing to survive and create the conditions to let them thrive. There are countless examples we can take of ways to implement this. For example, a universal job guarantee would put an end to involuntary unemployment and create good jobs to do important work sorely needed by Canada. It would also put pressure on the private sector to compete on wages and job conditions. Finally, we must universalize access to basic services that create high quality of life: childcare, education, health, and pharmacare more broadly defined, elder care, and so on. We can't limit opportunities based on race and economic position any longer. It's just so unjust and so unbecoming of a country with so much to offer. So there you have it. There's no half-hearted way out for resolving COVID-19 inequities. Even if we developed Band-Aid policies, we'd be right back here talking about this or another racial health inequity soon. Because that's how it works. Without resolving the fundamental structural issues involved of systemic racism and its impact on economic security, nothing ever changes. And that's simply not fair for any Canadian to be subjected to. While the policy solutions I've laid out are bold, they are very doable. Many scholars have highlighted how these policies can be designed and paid for. It's our responsibility.
If you could wrap up, please.
Sure. It's our responsibility to do better by all our people, and I certainly hope we do so. Thank you.
Thank you, Doctor. We'll go now to Dr. McKenzie. Dr. McKenzie, please go ahead. You have 10 minutes.
Thank you for inviting me to speak, Mr. Chair and honourable members, to this standing committee. I am a physician and also the CEO of Wellesley Institute, which is a think tank that aims to improve health and health equity through research, policy, development focused on the social determinants of health. This morning, you should have been given the executive summary of a briefing note we have submitted to the Standing Committee. The executive summary gives more detail on the recommendations I'm making today. The full briefing note goes into background and gives references to my comments. I'd especially like to thank Erica Pereira, the procedural clerk, for getting the executive summary translated so quickly. So, survival for those on the Titanic over a century ago was directly related to their social status. 60% of those in first class lived, 42% of those in second class, but only 24% of those in third class. The Titanic's escape plan was the same for everyone, but third class passengers were in lower internal berths and had difficulty getting to the lifeboats. The huge death toll was because there was not an adequate plan for them, though they were the passengers most in need. Fast forward 108 years to Canada's COVID response, and this has actually been really good. We've done really well. But like the Titanic, we have not developed an adequate plan for our highest risk populations, such as people living in congregate settings, those with lower incomes, and of course, our racialized populations. Our initial response was focused on flattening the curve, not who was under the curve. If we'd focused on both, we'd have had a better response and we'd have saved thousands of lives. We now need 4 groups of actions to ensure that our current and future responses to pandemics are equitable and are better. First, we need legislation that ensures that our public health responses are COVID-19 health and public health plans. Third, we need equity-based social policy and recovery plans which ensure that the most hard-hit populations are served properly. And last, we need data streams, research and capacity building to ensure that we have good sociodemographic, race and ethnicity information on which to build and monitor public health, and social policy interventions. I'll go through each one of those in a little bit more detail. Recommendation 1, which is about legislation. And we've actually seen racial disparities in infection rates and deaths in previous pandemics. During the H1N1 pandemic in Ontario, the Southeast Asian population were 3 times more likely to be infected, the South Asian population 6 times more likely to be infected, and the Black population were 10 times more likely to be infected than anybody else. Despite this, we didn't change our systems to collect sociodemographic data, and we did not do research or sit with communities to try and find out why the disparities exist. So we went into COVID-19 without surveillance systems or knowledge that would help us identify and deal with racialized health disparities. And then we set up a Titanic response, a one-size-fits-all, color and culture blind pandemic plan, which was predictably going to lead to health inequities. Now, some have argued that this was negligent. I just say it shouldn't be legal. We have legislation for things we care about. We do not leave them to the largesse of professionals, public servants, or politicians. If we want public services to produce equitable responses, we should enshrine this in enforceable law. Recommendation 2, equity-based federal and provincial COVID-19 health plans. We would have a fairer response if we took a health equity approach to what is left of the first wave, to the second wave, and to the recovery. A health equity approach aims to decrease avoidable disparities between groups. It ensures that people with similar needs get a same pandemic response, and people with greater needs get a bigger response. Now, there are actually lots of evidence-based tools out there, such as health equity impact assessment, which could be used to build these sorts of response. And they have been shown to be effective in public health in Canada. But when we build equitable plans, we also have to work with communities. We have to work with them to develop strategies that allow them to protect themselves from COVID-19. The third recommendation is saying, well, let's have those equitable plans, but also let's link to what Dr. Siddiqui was talking about, because health equity recognizes that the risk of illness and the ability to recover are not just linked to health interventions, but also to the social determinants of health. And the Canadian Medical Association has calculated that 85% of our risk of illness is actually linked to these social determinants such as income, housing, education, racism, and access to healthcare. Now, this actually offers significant policy opportunities for improving health because many health disparities are actually avoidable. COVID-19 actually harms health in four ways: through the disease itself, through the side effects of public health response, from healthcare changes such as cancelled operations, and by the downturn in the economy. These interact with the social determinants of health so that some parts of our population are harder hit than others. And as Dr. Siddiqui said, Canada's Black populations have been hardest hit by COVID-19. So our pandemic social policies and recovery plan need to be developed so that they decrease inequality and reach the hardest hit people. Decreasing differential risk linked to social determinants of health is actually an important intervention here, and probably one of the most important interventions. And the idea of a focused recovery plan for the hardest hit populations would not only improve our response, but would make those populations more resilient to future pandemics and future waves. And the last is numbers and data. I'm a researcher, I'm in a think tank. Numbers and data we think are vital, and they have been vital in the fight against COVID. We've relied on the number of cases, the number of deaths, and suddenly everybody understands what an R number is, which I never thought would happen in my lifetime. Numbers are also useful in indicating whether our interventions are working for everyone. And to do this, we need disaggregated data. And we desperately need better data streams on race and ethnicity and other social determinants of health for COVID-19 and actually for health in general. We need similar data, of course, for social policy. These data need to be good quality, and there needs to be good data governance and accountability. Communities increasingly want to say in and control of the use of their data. Wellesley Institute recommends that Canada collects individual level socio-demographic data for COVID-19, including race and ethnicity, that Canada urgently undertakes innovative analysis using existing data to get as accurate a picture as possible of disparities, and that Canada develops a strategy for ongoing socio-demographic data collection, including race and ethnicity, for health and social policy. But data is not an end in itself. Data has to be linked to meaningful strategies to decrease disparities. This will mean engagement with communities, it will mean research, and it will mean action to develop equitable public health and social policy interventions. So in conclusion, public health is the art and science of preventing disease, prolonging life, and promoting health through the organized efforts of society. Health equity interventions and the concept of social determinants of health are important tools for helping us to organize the best pandemic response. They are also a sound basis for health and social policy. The one-size-fits-all strategy actually led to a huge death toll on the Titanic, and so far, it's led to a significantly increased death toll for some parts of the Canadian population during the COVID-19 pandemic. If we want a COVID-19 response and health systems to be more fitting for the 21st century, we need legislation which ensures equity. We need equity-based COVID-19 pandemic plans. We need social policy and recovery plans focused on decreasing current inequities. And we need data streams and research which allows us to properly identify risk groups, build appropriate interventions, and monitor their impact. If we can put all of these in place, we'll move Canada's good response to being a great response and will save lives. Thank you very much.
Thank you, Doctor. We'll start our questions. We will do 2 rounds of questions. We will start the first round with Mr. General. Mr. General, please go ahead. You have 6 minutes.
Thank you, Mr. Chair, and thank you for the witnesses for being here today. Fascinating testimony indeed. Dr. Siddiqui, just follow up on something that you said. Have you had success in obtaining some of the demographic information in which you've talked about outside of just the Toronto, Greater Toronto area? More specifically, is the data on the location of cases available across Canada? I know, for instance, Ontario has a map where it highlights COVID clusters, but is there anything being provided at the federal level that would be helpful to you? I think you're on mute.
Thanks. Sorry about that. Thanks very much for that question. So there's sort of 2 parts to it, and I might defer to Dr. McKenzie to help me out with his understandings of what data are available. There's actually 2 issues. One is the short answer is no, I haven't, but there's 2 reasons why. One is that it's unclear to me the extent to which the data that are available, which tends to be area level socio-demographics that we collect from the census. So when the census is done, we get a sense of how Canadians are distributed across socio-demographic factors. And we don't release that information, at least at all readily at the individual level, but we do allow people to access area level information. That needs to be linked right now to COVID cases, which is how we figured out what's happening in Ontario without understanding what individuals look like. So what I'm not sure of is whether other provinces have done that to the same extent, but it would be doable. The second part of that is that it's worth saying that I personally have not accessed any of this data because we have a system in Canada in which agencies and institutions hold the data and they decide who gets to access it. And that's very unlike, for example, the United States, where we can download these things off the internet. And there's a lot of research activity that's happened there, a lot of information and analyses that have been generated about that society, precisely because independent scientists can readily ask these questions of the data rather than relying on agencies and institutions that have a lot of barriers for doing so.
Great, thank you. So I interpret from that it would be helpful to have some of that national perspective data. So perhaps that's one recommendation we can give to the department. Mr. Chair, being that this might be one of our last meetings, do want to use my time to proceed with moving of 4 motions. I'm certainly happy to read them. I have the 4 in front of me here. I ask you, I guess, if you'd like me to read through each one, if you want me to suggest. I know we all have them in front of us, but I would like to move those 4 motions at this time.
Thank you, Mr. General. You have the floor, so you can, in fact, move the motions. If you do move them, you need to move them one at a time, and we can deal with them one at a time. I should also advise that we are going to an in-camera session after our second panel, so perhaps you might wish to choose to move it there instead.
I appreciate your advice, Mr. Chair. I'll proceed with moving of the first motion. I'll start with the longest motion. If you want me to dispense at any time, please let me know. But I do move the motion that pursuant to Standing Order 1081A, the committee send the following documents to be provided by the government by Monday, August 3rd, 2020, and that the documents be published publicly on the committee's website by Monday, August 10th, 2020. All documents, briefing notes, memorandums, and emails regarding the emerging evidence that altered the government's advice on the wearing of masks referenced by Dr. Theresa Tam, Chief Public Health Officer, at her appearance before the Standing Committee on Health on Tuesday. May 19th, 2020, including all documents, briefing notes, memorandums, and emails to, from, between Health Canada, the Public Health Agency of Canada, the Minister of Health's office, the Privy Council, and the Prime Minister's office regarding the management of the National Emergency Strategic Stockpile from 2015 to 2020, including supply inventory broken down by number, and all updates sent to the government and the Government of Canada's contracts for PPE since January 2020.
Thank you, Mr. General. Is there any discussion? If there is discussion, please, on the participants panel, please signal your wish to speak by raising your hand. I see Dr. Jaczek. Dr. Jaczek, please go ahead.
Thank you very much, Chair. I was wondering if Mr. Generou would consider possibly amending part of his motion, in particular the reference to emails. As you will recall, no doubt, when we did pass a couple of motions previously, I think it was the decision of the committee that, in fact, that would be not particularly helpful. It would obviously be a huge amount of work in terms of collecting those emails, and would not necessarily substantively assist in what is really the goal of the motion, which is to find substantive documents in relation to government's action. So I would like to make what I consider a friendly amendment to actually delete the requirement for emails to be included.
Thank you, Doctor. Mr. General, I see your hand up.
Yeah, thank you, Mr. Chair. I guess I was anticipating something along those lines. I would indicate to the member and to other members that emails obviously are important in the back and forth of this, because we know that that's how one way in terms of how they communicate. We also want to make sure that, because nobody here is in the government, nobody here knows what those emails say, so it's helpful to the entire committee. Also, with reference to the last minister that we had before us, the Minister Champagne, he referenced text messages being important. I know we seated on text messages before. That that all being said, I know these are important witnesses that we all want to get to. So for this particular motion, we'll agree to, I guess, a friendly amendment, Chair, if that's what it's called, to remove on the line all documents, briefing notes, memorandums, and emails, and leave it at all documents, briefing notes, and memorandums.
Thank you, Mr. General. Do we have unanimous consent for that change? And for that, I'll just ask if there anybody is in dissent to please speak up. Hearing no dissent, I think we shall deem that the motion was moved as Mr. General has just signified. I see now Mr. Fisher. Please go ahead.
Sorry, Mr. Chair, can you just, I was going to agree to the removal of the emails as Mr. General had suggested and Ms. Jaczek has, but were you suggesting now that we're voting on the motion, or we're voting on that unanimous, and then if there are other possible amendments to this motion, they would come after that?
We're not actually voting. I'm just asking if there is a unanimous consent for us to consider that Mr. General has moved his motion without the reference to emails.
Gotcha.
And any further discussion on the motion is in order. So, seeing no dissent for the unanimous. I see Mr. Weber. Are you dissenting
Yes,
from the unanimous consent?
I am, Mr. Chair. I think it is important to receive the emails as well. Understand that it is a bit more work involved, but these these emails, I think, are important. So it will not be unanimous. I will dissent this. So thank you.
So since there is no unanimous consent, if we wish to make that change, it will have to be done by an amendment. Does someone wish to move such an amendment?
I will move, I guess, that we remove the word emails from the motion.
Very well. So now the discussion is on the amendment. Is there any further discussion on that matter? Seeing none, I think we will call a vote. Madam Chair, if you would please call a vote on the amendment, which is to remove the reference to emails, and that would be, and of course, appropriate grammatical corrections accordingly.
Thank you, Mr. Chair. The vote is on the amendment. If you're in favor, say yay. If you're opposed, say nay. Mr. Fisher.
I'll vote yay on the amendment.
Mr. Kellaway.
Yay on the amendment.
Mr. Sheehan.
Yes on the amendment.
Ms. Jasek. Yes. Mr. Van Bynen.
Yes.
Ms. Jansen. I'm sorry, Ms. Jansen, I did not hear you.
No.
Thank you. Mr. Generu.
No.
Mr. Kitchen.
No.
Mr. Weber.
No.
Monsieur Desilets.
We.
Yes.
Mr. Davies.
We.
Yes.
The results are 4 against and 7-4.
Very well. So the amendment carries. We will now continue our discussion on the motion as amended. If there is any discussion, please raise your hand on the participants panel. I see Mr. Fisher. Mr. Fisher, please go ahead.
Thank you, Mr. Chair, and I'm wondering if Mr. General would be willing to remove the PMO and the Minister of Health's office from this as well.
No. Nice try.
Thank you, Mr. Fisher. Was that a motion or did you just a comment?
I will move that remove those then.
Thank you, Mr. Fisher. So we will discuss Mr. Fisher's amendment, which is to remove the references, explicit references to the PMO and I'm sorry, Mr. Fisher, would you please clarify?
The Minister of Health's office.
Minister of Health's office and okay. So the discussion is on Mr. Fisher's amendment. We have Mr. General has raised his hand. Please go ahead.
Yeah, thanks, Mr. Chair. No, obviously, we believe it's important. I don't know what this particular member thinks that. Sorry, am I still going? I was receiving a phone call at the same time. Sorry. Yeah, I don't know what this particular member is trying to hide between these two. Trying to do this quickly because I know we want to get to the witness testimony here, but it's obviously it's crucial to hear from the advice that was given to the Minister of Health's office and the Prime Minister's office because they were the ones who were doing the public statements on masks at the very beginning.
Thank you, Mr. General. I see Ms. Jansen now has her hand up. Please go ahead.
Yes, it just concerns me. We started out with being told that to give text messages was too much. Now we're saying that we're taking emails is too much, and now we're actually going to just take out the PMO. I find it mind-boggling that everything's too much. So something's very important. We need to get to the bottom of this. So yes, I'm just boggled by this one.
Thank you, Ms. Jansen. We have, I see Mr. Davies. Go ahead.
Yes. Thank you, Mr. Chair. I just want to say two things. One is I support the motions of my colleague to be transparent and hold the government accountable and to receive information that I think all parliamentarians should be supportive of putting before the Health Committee. But I am very mindful that we have two excellent witnesses here who I think are giving particularly important testimony today, particularly in light of the global focus on racism in this country. And this is the first time we've really looked at the impacts of COVID-19 on marginalized populations. And I'm just wondering if it wouldn't be better if we take these motions, and I certainly for one would support holding a separate meeting where we could deal with these motions, because I'm concerned that if we continue talking about these motions, we will not have a chance to take advantage of this wonderful expertise we have before the panel today and ask questions. So I wonder if Mr. Generou would consider withdrawing the motions at this point. If we sign I think it's a section 106 or 104, I can't remember the section. If four committee members agree to hold a meeting, then a meeting must be held. I certainly will support that, and then we can deal with these very important matters, but housekeeping matters, in a separate meeting, and get to hear from these excellent witnesses here today.
Mr. General, I see your hand is up. Please go ahead.
Thank you, Mr. Chair, and wholeheartedly agree with my colleague, Mr. Davies. Obviously, want to get through this as quickly as possible. These motions, are very straightforward, in my opinion. Attempted to streamline it there at the beginning. I think this is a bit of an overreach from the government, the particular member. But if we go to vote right away, I think we can get through these quite quickly, and we can move this along and get back to the important testimony from the witnesses.
Thank you, Mr. General. And to the witnesses, I would point out that we are certainly mindful of your testimony and your valuable expertise. However, we do have to take motions when they come, and we will continue with. I see Ms. Dr. Jaczek, your hand is up, please. Go ahead.
Thank you, Chair. And certainly, I do find the testimony that we've heard today extremely important, and would certainly like to have my opportunity to question the witnesses as well. However, we are now dealing with this motion, and I was wanting to move yet another potential amendment, very much mirroring the wording that we passed a couple of weeks back on a motion proposed by Dr. Kitchen.
Pardon me, Doctor. We do have an amendment on the floor. We have to deal with that before we can entertain further amendments.
Exactly. So what I'm trying to say is I would definitely feel we need to continue this discussion.
Okay, thank you. I see Mr. Kellaway. Go ahead.
Thanks, Mr. Chair. And I just want to echo what MP Don Davies said. I absolutely believe we have to have this discussion with respect to the motions on the table and, of course, our response and our suggestions to them. And at the same time, we have some, as Don Davies mentioned, MP Davies, this is an important conversation as well that I think if we could look at whether it's a separate meeting or an in-camera meeting, we can address and discuss collegially the motions on the table, and at that point being able to provide some feedback into those motions.
I see Monsieur Desilets, I think you're raising your physical hand. I'm looking for you on the participants panel. We do have a speaking list that is coming from there. I'll give you the floor, however, in any case. Please go ahead, Mr. Desilets.
Mr. Chair, I agree with some of my colleagues, such as Mr. Davies. We are having really we are having expert testimony by very competent witnesses. I understand that there are motions that have to be dealt with, but for me, the best way of dealing with them would be to deal with them separately. Outside this particular committee meeting, I'm quite embarrassed to deal with some of these motions and to have to present this, to deal with this during these witnesses testifying. I think that this is not the time to deal with these motions. We have two expert witnesses here, and I fear that we'll have the same issue during the second panel. And I would like for you to make to take a decision that this motion be that it be dealt with outside of today's meeting at another time, and that we would be able to use the time we have today to ask questions of these expert witnesses. They have a very, very different content, and and it really bothers me to not use this opportunity fully. So I think that the discussions around this motion should be separate. Thank you.
Thank you, Mr. Desilets. It is the member's prerogative to move the motion when he has the floor. As long as that's the case, we have to deal with it as it comes. I see Mr. Van Bynen. Please go ahead.
Thank you, Mr. Chair. I agree with Mr. Callaway and Don Davies as well. We have some very valuable expertise in front of us today, and the opportunity may not present itself to be included in the reports that we will be discussing. And although the process and procedure permits the debate now, I think out of good conscience, in terms of getting a high value report in front of the people who will be reading it, we are missing an excellent opportunity for us to hear the benefit of Dr. Siddiqui and Dr. McKenzie. This is something that should not be waived so quickly. And if any members would put forward a motion to adjourn the debate so that we can hear these witnesses, I would be happy to support that as well. But to me, I think this is an excellent and an important opportunity on a very significant issue for our country that can really influence the future that we take, not just for this, but also for any future issues where we're creating pandemics and needing to decide equity versus equality. So this is an opportunity that should not be missed, Mr. Chair, and I believe that this debate should move forward to another meeting.
Thank you, Mr. Van Bynen. I see we have Mr. Davies as well. Please go ahead.
Well, I don't know, Mr. Chair, if this motion's in order, but I think that I'm detecting a majority support. I would move a motion that we table all four of Mr. Genero's motions and schedule a separate meeting in public, because I do believe these should be debated in public, so that we can get back to hearing these witnesses today. And I'm going to hasten again that, I find it ironic that we have witnesses who are talking about the historic suppression of marginalized groups and their lack of voice being taken into account in public policy. And here we are in a meeting doing that same thing. And I think it's particularly unfortunate and frankly worthy of sanction to do so in this meeting. So I would move that we table these motions and schedule a separate meeting as early as possible to discuss in public all four of these motions.
Thank you, Mr.
Chair.
Davies.
My hand's been up for a while here. Not sure what.
Sure, I'll just respond to Mr. Davies and I'll give you the floor. Sure. Mr. Davies, the motion that you made is not in order at this time. What would be in order would be a motion to adjourn the debate on this. I will.
Then so moved.
Okay. So we do have a motion to adjourn the debate. And before we entertain that motion, I wonder if Mr. General had a comment that would help us in this matter.
Yeah, Mr. Chair, obviously want to make sure that we get as many people as possible. At the beginning, tried to play nice with the government and try to move this along. Unfortunately, going after the one key aspect of the motion isn't playing nice at the end of the day. I'd respectfully, I guess, ask it's with now with I guess two motions on the floor. I'm not sure this would be in order, but perhaps if we were to look at, I don't feel your original suggestion of being in camera is the right suggestion, Mr. Chair. But I do feel if we were to entertain perhaps a half hour or an hour after this particular meeting, it would be. I know there's no meetings that are meeting after us. I believe the clerk can confirm if we have the room still, where we could debate these motions in public. I'd certainly be happy to do that, table these now and move to that. However, I'm not sure if that's in order, but I'll leave it up to you to determine if I can withdraw a motion or not at this point in time.
Thank you, Mr. General. So, Mr. Davies' motion is in order. However, if we are in unanimous agreement to move to set up a separate meeting for this purpose.
Just to, Mr. Chair, sorry, for just a point of order. Sorry to interrupt, and I don't know this committee stuff like you would, but Mr. Davies was talking about moving a motion for a separate meeting, but then moved a motion to adjourn debate. I think I would just like to ask maybe the clerk, like, what happens when he's then moved that? I understand that there's no discussion after a member has moved to adjourn debate. I'm just seeking clarity. Thank you.
That is correct. However, I'm for us to execute Mr. Davies' motion to adjourn debate, which we can certainly do. We will then have three other motions to deal with. So I'm proposing that if we have unanimous consent to do that, we could ask Mr. Davies to, we could have unanimous consent to withdraw Mr. Davies' motion if he wishes, and unanimous consent to withdraw Mr. Genero's motion at this time, and to take it up at another time. So
I see. See, you are smarter than me.
We can do things by unanimous consent, but if we have no unanimous consent to act in this way, then we will deal with Mr. Davies' motion and take the other motions as they may come. So, Mr. Davies, would you be in agreement with such an approach?
I would, Mr. Chair. I mean, it seems to me that we might be able to short circuit all of this. If I heard Mr. Generou's very generous and reasonable suggestion, I think what I heard him to say is we can withdraw everything at this point and simply deal with these motions after we hear the witnesses in both panels today, which I think gets everybody to the point that we're agreeing on. So, perhaps if you seek unanimous consent, we can agree to table all of these motions to the end of this meeting.
All right. So I will ask if we do have unanimous consent. I'm sorry. After the end of this meeting, we don't have time in this today to deal with all of this stuff. We will have only 20 minutes for an in-camera meeting, if we still have time even for that. I'm proposing we set up a separate meeting perhaps next week to deal with this. And I'm asking if we have unanimous consent to do that.
Mr. Chair, just a quick point of order on that, though. I do believe there is no meeting after us. And I think that was part of my request to confirm with the clerk that we could continue on if we wanted to for that extra half hour or not.
My information is that we have a hard cap at 2:40 Eastern time. In any case, let us, we're getting a little involved here. Do we have unanimous consent to withdraw all the motions now on the floor and to take them up instead on a meeting to be called for this purpose at a time to be arranged with the clerk, but possibly early next week? Is there unanimous consent for that? In fact, I'll ask the clerk to take a vote on this, just so we're clear.
Sorry, Tamara here. I'm just wondering, are you going to give like a time cap as well on by what time we have to have this extra meeting? Because you're saying possibly next week, but what if that doesn't happen?
Well, I'm just saying that we will ask the clerk to arrange a time for the meeting at a time that is suitable to all of us, but certainly a time that I don't know what the schedule is like next week for things, but we will have a separate meeting for that.
I just wonder if we can make sure that there's a time limit, like that we don't wait a month.
Well, we're not going to wait a month. The whole business of unanimous consent is a matter of achieving some consensus. We understand that it's an important matter we need to deal with. We will deal with it as in a proactive way. We just don't want to deal with it now, right? We want to get back to our witnesses. So I don't have a specific date and time for
sooner than later.
We put
our trust in you, Mr. Chair, to find it sooner than later.
Very well. I appreciate that. And that being said, if everyone is in agreement, let's find out if we are in agreement. So I'm asking for unanimous consent to deal with these matters in a separate meeting called for that purpose, to be arranged with the chair and the clerk, and at a suitable time in the near future. So are we in agreement unanimously on that? I'll ask the clerk to take a vote, please.
Thank you, Mr. Chair. Mr. Fisher.
Agreed.
Mr. Callaway. Mr. Callaway, I did not hear you.
Sorry. Yes, agreed.
Thank you. Mr. Sheehan.
Agreed.
Ms. Jacek.
Yes.
Mr. Van Bynen.
Yes.
Ms. Jansen.
Yes.
Mr. Genereux.
Yes.
Mr. Kitchen.
Yes.
Mr. Weber.
Yes.
Monsieur Desilets.
Oui.
Mr. Davies.
Yes.
Mr. Chair, that is 11 yeas.
Thank you. So we have unanimous consent. The motions are deemed withdrawn. We will schedule a meeting for the purposes of dealing with Mr. Genereux's motion as originally moved today, as well as the other motions he wishes to move today, or he had wished to move today. And we will carry on with our questioning. Thank you very much, everybody, for your cooperation. And with that, we will return to our questioning. Mr. Genereux, your time is up. And
actually, Mr. Chair, I do believe I have some time, because the time stops when you call a motion, as you well know. But in the interest of the committee's time, and I want to make sure we get the NDP and block opportunity as well to ask questions, I will cede the rest of my time back to the chair.
Thank you, Mr. Genereux. You actually are correct, but thank you. And we will go now to Mr. Fisher. Mr. Fisher, please go ahead. You have 6 minutes.
Thank you very much, Mr. Chair, and I want to thank the witnesses for being here, but I also want to thank Mr. Genereux. This is part of the process of committee, and he has every right to move those motions, and we could sit here and talk about those motions and work them out and hash them out for the full couple hours of the meeting. So thank you, MP Genereux, for agreeing that we could seek some type of discussion at a later date. Dr. Siddiqui, first of all, I just wanted to say that both of you gave so much wonderful testimony that is so valuable. One of the MPs, I think it was Mr. Van Bynen, commented about the importance of having this testimony in our report, and this was our last meeting to get your testimony into this report. So that makes it so important that we get this testimony. Now, if I ask you a question that you feel that you've already sort of touched on, feel free to broaden those comments if you wish, because you gave so much stuff, and I was trying to scribble things down, and it just wasn't possible. So starting with you, Dr. Siddiqui, the pandemic, we agree, is disproportionately affected vulnerable communities. How can we do better going forward to address this disproportionate effect?
Thanks very much for the question, and I'm happy to expand. I think the way to do better is to understand what caused their vulnerability in the first place. So there's two approaches that we could generally think about. One is to mitigate the harm done to vulnerable people. But the first is to ask, why are people vulnerable in the first place? What makes us sort people into being vulnerable and not? And what we've learned from the literature is that this issue of your social and your economic position, in particular your race and your social class, creates an inherent vulnerability, and that without addressing the fact that life, material conditions, stress, opportunity, and so on are fundamentally sorted by race and class, we can't possibly hope to do anything about what then the eventual outcomes of that vulnerability are, which are things like COVID-19 inequities, cardiovascular inequities, hypertension inequities, educational inequities, employment inequities, and so on. And so I think what we can do is take a good, long, hard look at how we structure opportunity in our society and say to ourselves, we want a society in which the policies and the institutions create opportunity for everybody. And I think, as one of the members eloquently said earlier, it's the distinction between equality and equity, in the sense that you want to make sure that, knowing we don't have an equitable society, it's unfair to some, that we start to look at key policies that would get us to equity, that would not just unfold opportunities as if they can be equally taken up. So, a great example is, if you think about, post-secondary education, you could make an argument that anyone can apply and that this creates some equality. We don't stop anybody from applying. If you make the grades and so on, you can get into school. But that's not actually how it works. Because you have to be able to pay for school. You have to have teachers that have supported you in feeling like you can make it to that point. You have to have an environment around you that doesn't cause you so much stress that you can't focus on your studies, and so on. Well, the same is true for COVID. Yes, we could all shelter ourselves and social distance and technically, avoid COVID, but that's not actually how things work. Some of us are more exposed than others by virtue of our vulnerable position. So I think what I'm suggesting is that, as counterintuitive as it may seem, the fundamental injustices of making some people vulnerable in our society is really the way to tackle the outgrowth of that.
Dr. McKenzie, you listed many of your recommendations, and again, I was scribbling as fast as I could, but do you care to comment on this before my time runs out?
Yeah, sure. And thanks very much for the question. And I completely agree with Dr. Siddiqui that, we need to go fundamentally towards equality and equity, and that there are these fundamental causes that are driving disparities. The problem is, a lot of the things you're going to do to try and deal with those fundamental causes are not going to happen during this pandemic, first wave, second wave, or in the recovery. And so the question is, what can we actually do now? And what can we actually do that can practically help this group move towards a more equitable response? I do believe that we will find, if we have the data, that different jurisdictions have had different success in producing equitable responses. And I'm completely sure of that. We know that different jurisdictions have got completely different rates of COVID, whether you look at BC and compare it to Quebec and Ontario. These are very different outcomes. In fact, if both Quebec and Ontario had the same quality of response as BC, there'd have been about 2,000 lives saved in Ontario, and there'd have probably been about 4,000 lives saved in Quebec. So there are big differences in the way we've gone about things. And if we can even get to the point of equalizing how well the different provinces have dealt with COVID, we would move towards a better outcome for all. So this idea of legislation is to try and promote equity through legislation, to make sure that provinces actually think equity when they're thinking about their pandemic plans, because at the moment many don't, and that's why we see some of the disparities. Not all of the disparities would be dealt with by thinking about equity in the pandemic plans, but certainly because, as Dr. Siddiqui said, there are fundamental causes of these disparities, but we can certainly make our response better and more equitable, and we can certainly save lives by using a health equity lens. And then going forward, when we're looking at the recovery, we need to use the opportunity of the recovery to try and decrease some of the fundamental drivers of inequities. And so I think there are things we can do now directly on our pandemic plans, and then also on our recovery plan, which will actually make us more equitable and will save lives. I also think that not having the data, in my mind, is criminal. It's 2020, right?
Yeah. Thank you, Mr. Fisher. Nous allons maintenant à Monsieur
We will now move to Mr. Desilets. Monsieur Desilets, you have 6 minutes. Thank you indeed, Mr. Chair. Thank you to our two guests who have been delivering fascinating presentations as different from other witnesses. Let me ask Dr. McKenzie a question. I really like your example, quoting what happened on board the Titanic. And this is quite graphic and convincing. And you said at the beginning of your comments that the Canadian response to COVID had been positive. Can you please explain and elaborate on its positive qualities? Because when one listens to what you say afterwards, it is less positive than you posit at the beginning. And regarding the Black population, we have been completely unable to deal with the situation. Thank you, Dr. McKenzie.
Thank you, Mr. Desilets. I would bring you back to some numbers. So if you look at the death rate per 100,000, in Canada, it's been about 23 per 100,000. If you look at somewhere like the United Kingdom, it's been 50 per 100,000. In fact, Canada's rate is pretty good compared to many high-income countries. And so we've done reasonably well. Obviously, if we compare ourselves to Germany, which has a rate of 11 per 100,000, we haven't done as well as Germany. In fact, if we had a response that is as good as Germany, one analysis has shown we'd have saved 4,528 lives. So we've done, we're in the middle of the pack compared to lots of others. We've done very well. It could have gone a lot worse. The problem is, inside that good response, it's worked better for some people than other people. So my comments are that we have done well, but if we'd have done equally well for everybody, we'd have all been better off, and the death rate would have been significantly lower, and the morbidity would have been significantly lower, and we would have been in a better place in order to rebound into the recovery.
Dr. McKenzie, have we got data which would enable us to make comparisons with other countries which have more or less the same percentage of population between white people and black people? As an example, because you were making comments on the death rate, 23 out of 100,000 in Canada. Yeah, that's good. But if we look more in depth at the results, can we make a comparison with Canada?
That's a really interesting and important question. It is very difficult to make comparisons between countries. but also most of the excess deaths which are linked to ethnic group are not linked to biology. They are linked to people's social situations. And people's social situations are linked to policy choices. So yes, we could say, oh no, we can only compare ourselves to populations that have similar ethnic groups. But to a certain extent, that makes it sound like race is the determinant, but race isn't the determinant. Social policy and racism is the determinant. But of course, if we were to look at somewhere like Germany, Germany has a significant migrant population. It has a significant ethnic diversity, including a very large Turkish population, but they have still managed to have a better response than us.
Okay. Merci beaucoup.
Thank you indeed, Dr. McKenzie, for your answer. And then you mentioned the fourth element, which is linked to how important it is to have pan-Canadian results to our policies. And several witnesses did underline this lack of efficacy due to the fact that there is not enough cooperation from one province to another, and that we would not have to wait for a full year until we have pan-Canadian statistics which would enable them to draw up public policies. And some countries are much more efficient than we are, and they have established more centralized systems for managing the data which have been collected. So who would be responsible for doing such a thing, this centralization and consistency and networking between the various entities, and taking into account the fact that we have the provinces and the federal, and people seem to be passing the buck?
I do think that there are significant difficulties to data collection which are produced by the federal, provincial and territorial split. But I do think that the federal government itself can make sure that it gets its own data house in order. It is surprising that we have a census, and in our census, we do not collect from everybody information on sociodemographic and race and ethnicity information. We collect it from only 20% of people on the long form census, rather than 100% of people on the short form census. If we were able to change the short form census so we got a full picture of Canada, we would be able possibly to link that census data to other data to get a good picture of our pandemics and a better picture of our pandemics. So it is possible to do these things, but at a federal level. And it is also possible for the feds to insist that the provinces produce data. At the moment, the feds pay a lot to the provinces, and maybe the provinces should be thinking about how maybe the feds should be thinking about what data the provinces produce in order to demonstrate that they are collecting, that their responses are actually equitable. Very few people would give money to a company or a service without being very clear what they're getting in return. And at the moment, sometimes federal transfers are not transparently linked to productivity, and especially not to productivity based on equity.
Thank you, Mr. Desilets. I'd like to advise the committee that we have set up a time for our next meeting to be 3 o'clock Eastern Time next Monday, at which time we can deal with Mr. Genero's motion. We will also move the drafting instructions from today to following that meeting. We will still be tight on time today, but we will do our best to get both panels in and both rounds. So thank you all. And with that, we go to Mr. Davies. Mr. Davies, Please go ahead. You have 6 minutes.
Thank you, Mr. Chair, and thank you, Dr. Siddiqui and Dr. McKenzie, for sharing your expertise with us today. I think both of you have laid out a very clear and powerful case for why the federal government needs to collect comprehensive national data on socioeconomic and other factors. Dr. Siddiqui, you recently wrote that the Canadian government has been reluctant to routinely collect race and ethnicity data, and the consequence is a lack of accountability, according to your writing, in addressing racial disparities in all sectors of society. In your view, why has the federal government been reluctant to collect race and ethnicity data with respect to COVID-19 and in general?
Thank you very much. I think what I can tell you is what we often hear is the primary reason, and then speculate about what might be going on. So what we're often told is that the reason to withhold this data, not make it sort of publicly accessible, not collect it more widely, et cetera, is really an effort to protect the privacy of Canadians. That there may be some issues, particularly around sort of general release of the data, that would compromise the safety and privacy of Canadians, were those data to be able to identify particular Canadians. And we have very little reason to believe that that is enough of a concern to suppress really valuable information. Is it somehow through de-identified data still possible to identify particular Canadians? Almost never. Maybe there's a slight outside possibility, but the way there is with census data for that matter, but not enough for me to believe that that's actually a legitimate reason not to be collecting this data and not allowing it to be freely publicly accessible, to be analyzed by people like myself, Dr. McKenzie, and others in order to inform our country about what's happening to us. So that brings me to what I think might be going on. And it's unfortunate, but I do think that when we don't collect data, it's at least one way in which we can ignore the evidence. We can sort of equate our own opinions with a claim that those opinions are facts, because the facts simply aren't available to us. And my sense is, as you pointed out, I've mentioned before, that with data and the ability for independent scientists to analyze that data comes a groundswell of evidence that in one way forces us to at least admit to the facts, to at least have to contend and confront and recognize the fact that there are, empirical evidence sources being put before us, rather than sort of a situation where anyone can say virtually anything, and we don't really have a good way to contend or refute with what people are saying. So I think that part of the hesitation may be that this actually creates some serious empirical demonstrations of what's happening in our society, that then, as Dr. McKenzie say, that's not the beginning. That's not the end. That's just the beginning. And that will sort of make us have to move forward with action.
Thank you, Dr. McKenzie. I want to focus on mental health for a moment. In a June 29th article from Global News, before moving to Toronto, you ran a mental health service in North London, UK. When someone with psychosis or another serious form of mental illness was in crisis, your team of medical professionals showed up first rather than the police. You noted in that article that this was possible because the UK funds mental health care in ways that Canada does not. Could you please provide the committee with further detail on the effectiveness of this program and maybe outline the key differences between the UK and Canada's approaches to funding mental health care?
So thank you very much for the question. I didn't know quite where it was going. I thought you were going to be talking about the echo epidemic of mental health that was going to come through COVID. The situation that we find in Canada in general is about 7% of healthcare spending is spent on mental health. In the UK, it's between 9 and 11%, depending on where you are. And so a lot more money is spent on mental health in the UK. Now, mental health, obviously, as you know, is about people. There's not amazing surgery to be done and all of the other things. There aren't loads of equipment. It's about people. So if you're not spending the money, you don't have the people. And if you don't have the people, you don't have the service. And so the difference I've seen in Canada compared to the UK is that there is not comprehensive enough mental health service, and there's not comprehensive community mental health service. And because of that, there are more crises, and there are many more mental health crises. And as you know, these can end up tragically. So the actual breadth and depth of mental health services is, I believe in Canada, is not sufficient to meet the needs of the population. And if we are to get an echo epidemic of mental health problems due to COVID, I believe we are going to have real problems unless we significantly start investing in building capacity to deal in the community and elsewhere with the mental health impacts.
Now, you spoke of the legislative
Thank you,
imperative.
Mr. Davies. We go now to, actually that ends round one. We'll start round two with Mr. Weber. Mr. Weber, please go ahead, 5 minutes.
Well, thank you, Mr. Chair, and thank you to our two doctors here today in your testimony, and incredibly interesting for sure. Mr. Chair, I certainly hate going behind Mr. Davies and questioning because, once again, he has brought up some points that I wanted to bring up. Don, I shake my hand at you, my fist. Anyway, it's along that same article to you, Dr. McKenzie, that article in the Globe and Mail, our Global News, regarding your experience in the UK, in North London, about the team of medical professionals that show up first, not the police, when there was a mental health crisis in the community. Now, you talked a bit about it. Can you just explain to us how this came about, how it worked, how you dealt with violent or armed non-cooperative people? I know this wasn't a part of your testimony today, but I think it is very relevant, the mental health side of it. So can you just elaborate a little bit more on how you began this?
So one of the things that we found, and one of the things we've always thought, is that if you can intervene early, you decrease the need for crisis intervention. So our team was very straightforward. It was community-based. Every person who we saw, they and their family, were given a telephone number that they could call anytime, and we would go and see them. And so, yes, we did all of the crisis calls. Yes, they called us first rather than the police. And yes, we went out to see them. And over the 3 to 4 years I was there, we had none of our staff injured and none of our clients injured. That didn't happen. Some of that is because we are experts in de-escalation and we are experts in dealing with mental health crises. And some of it is because people knew who we were, and that makes a difference. But a lot of it was because we saw people earlier in their diseases and earlier in their problems. So rather than waiting till things get so acute that people were ringing the police, families were ringing us early. And we were going to see people, and we were decreasing the problems. Community mental health services properly deployed are very important and work. Yes, we did have problems when people were very disturbed, and we needed to have the police as backup. But we led the response, and the police would be in the car outside. And if we needed them, we'd call them in. So we had them there, but we never had anybody put in handcuffs and taken and taken away. And part of the reason for that is traumatic. And even if it's done and the person doesn't get hurt, you then have to deal with the trauma. And so that's what we did. It worked well and expanded across London, and it's the way that things were done at that time.
I think that is brilliant, Dr. McKenzie. I think that we should certainly be looking at implementing something like that here across our country as well. So thank you for sharing that. A quick question to Dr. Siddiqui. Again, thank you for your presentation and sharing your experience on your studies of relationships between race and health outcomes. In an article in the Globe and Mail on June the 1st, you said that the United States was night and day different than Canada in race-based data collection. Can you better explain those differences, Dr. Siddiqui?
Yeah, sure. Thanks very much for the question. So I have a lot of experience with the US because I trained there and lived there for a long time. I still do a lot of research there. So that's the foundation of my comments. In the United States, they have routinized the collection of data on race the way we have routinized it on age and gender. In the United States, you answer a question about your race near every time you would answer any questions about your demographics or where you live. That means you answer it when you access the healthcare system, the education system, when you apply for a job, and when you actually get a job and your sort of address and information are collected. And then what the United States does is make that information, that data becomes publicly accessible. So you and I could right now go to the internet and access data sets that are either administrative, meaning they're the collection of this routine data, or they are government surveys, the way we have Canadian Community Health Survey and so on. We could just go to the internet, download that data with really good documentation about how to use it, and create analyses right now of what racial inequalities and socioeconomic inequalities look like. To give you another example, we're conducting some work on inequalities in birth outcomes in the US, and we can do that because birth certificates have information on race. And we can do it because that information is downloadable off the internet with ease. So I don't have to apply to request the data, go into a StatsCan data center to analyze it between 9 and 5, get certified to do that, tell them exactly what I'm going to ask, and then
Doctor, could you wrap up, please?
Yes, sure. And so there in Canada, what happens is there are all of these barriers, A, to collecting the data and therefore having data, but B, to accessing the data that we already have.
Interesting. Thank you very much, Doctor.
Thank you, Mr. Weber. And we go now to Mr. Van Bynen. Mr. Van Bynen, please go ahead, 5 minutes.
Thank you, Mr. Chair, and I do want to thank both of our witnesses for the very powerful information that they've given us. I was particularly interested in the analogy about, or the recognition that intergenerational wealth transfer was a root cause of systemic racism, and so I thank you for that. My first question is for Dr. Siddiqui, and it's my understanding that the Dalai Lama School of Public Health has a self-directed, student-led organization called the Infectious Disease Working Group that has created a community resource navigation tool. I'm hoping you can share with the committee a little more about the tool. What does the group hope to achieve with it? How was it developed? And what has the group discovered from the information it's obtained in the development of the tool?
Thank you so much. Yes, I'm very proud to say that that tool has been developed by us, a couple of our doctoral students taking the lead. Those are Isha Berry and Jean-Paul Scusi, and as well David Fissman, Ashley Tweed, and other of our faculty have been integrally involved in developing that tool. Essentially, the backdrop of that tool was to make up for the fact that there was not routinely available data on COVID, and we were in a crisis in which we wanted information desperately and needed to get information out to the public desperately. So with the ingenuity that that team has and their colleagues, they essentially took the media reports that were coming down the pike of who was dying from COVID, what their characteristics were, where they lived, and essentially assembled their own database. You can imagine this is painstaking work to put together a database that's not in any way automated, but really requires the blood, sweat, and tears of people extracting information wherever they can find it. In terms of what they found, a variety of things really came from that data. They were able to tell us how the pandemic was proceeding, where we were seeing hot spots, whether things were getting better or worse as days went on. What they weren't able to tell us is something about the inequities in terms of sociodemographics. So they tried to collect information on things like occupation and so on when it was available from a media report, but because they weren't relying on a source that has a standard information collection setup, they just really were at the mercy of whatever they could find. And usually that involved where people live and what age they were, and of course their COVID-19 outcomes. So it was really able to tell us a lot, but what's sort of remarkable is the fact that they did this in such short order and just with their own ingenuity and initiative, but also that they had to do this because we didn't have a government system of routine data collection that was publicly accessible.
Thank you. Would the outcome of that information be made available to this committee?
Yes, sure.
Great. Thank you. Now, my next question is for Dr. McKenzie. First of all, I really found enlightening your comment that it was important for us to understand what's under the curve as opposed to bending the curve. And a lot of that reflects some of the social disparities that we've heard about. My question would be that what changes would you like to see in the minimum wage, income supplements, and social assistance and supports to start putting some equity into the system?
So thank you very much for the question. I, as you know, was the research and evaluation chair for the Ontario Basic Income study. So I like the idea of a basic income. I like the outcomes of a basic income. I like the fact that it does improve equity, and I like the fact that there are health and mental health outcomes as well as dignity, and dignity and social inclusion are very important. I also like, when thinking about these things, I like the idea of us trying to think of how we think, when we're thinking of income supports, we tend to think about a level of money that we're giving people, but we never link that necessarily to the level that's needed for health. And so I'm very interested in whether, when we're thinking about how much EI people get, how much CERB that people get, that package actually allows people to be healthy, because that will help decrease disparities. I also think accessibility of these the packages like the CERB and others is very important. I have noticed a number of studies coming forward now showing that, say, for instance, the Black population, about 40% have lost income or their jobs over the pandemic, but a lower proportion of the Black community than others have come forward for social assistance and have got the CERB. So I think there are equity problems in the accessibility of things like the SERB. Some of it is due to people not knowing their rights. Some of it is due to the digital divide between people. But it's definitely there. So the big things I would say is when we're thinking about social assistance, can we link it to health and work out what people need to be healthy? Can we think of how we make sure it reaches the right populations and that they actually get it? The other things that I would suggest.
Thank you, Mr. Van Bynen. We go now to Dr. Kitchen. Dr. Kitchen, please go ahead, 5 minutes.
Thank you, Mr. Chair, and thank you, Dr. Siddiqui and Dr. McKenzie, for your presentations. Greatly appreciate hearing that, and a lot of some of what you talked about is that data is lacking, and the fact that we need to have ongoing data, and we've heard that throughout this committee, where data is a big challenge in collecting it and disseminating it, whether it's because of provincial barriers, federal barriers, et cetera. So it's grateful to hear those comments. You did talk about social inequality. And those are issues that you touched on in the issue of income. You talked about housing, you talked about race, et cetera. I've noticed in some of the research and doing a little bit of research on you beforehand that you have mentioned, both of you, on issues of persons with disabilities. And I'm wondering if you could comment on that, in particular in this particular demographic, and from both of you. And I'll start with Dr. McKenzie, and then maybe Dr. Siddiqui, you might be able to throw in some input. But just on your thoughts on how this is having a big impact on dealing with that. You know, you talked a bit about we need to hit the hardest hit group, and so I would like to hear your comments on that if I could.
So thank you very much for the question. I think it's really important to be thinking about disability. Certainly, when we've an analysis of, I think I mentioned before the analysis of comparing Germany to Canada. The big difference between Germany and Canada with regards to lives lost has been that 80% of people who've lost their lives in Canada are from long-term care, and only 34% of people who've lost their lives in Germany from long-term care. They sorted out long-term care, and that made a difference. In this way, the end of this wave and the next wave, I believe it's going to be vulnerable populations, such as people in congregate living situations, people with disabilities, who are going to be the next frontier for producing as quality and equitable response, along with the racialized populations. And so I think focusing on their needs, sitting down and working out what they need to be able to protect themselves is going to be important. As I said before, I agree with Dr. Siddiqui about the fundamental causes, but I also think that unless you sit down and say to people with disabilities, what do you need in order to be able to use the tools we've got? And we have the tools of testing, we have the tools of physical distancing, we have the tools of tracing. How can you do this? What stops you doing this? If we can start working those things out and finding innovative interventions, we might be able to protect a whole bunch of people in those groups, because that's what happened in long-term care in different countries. Countries that had really good policies on the prevention of infection in long-term care, and they launched them at the same time as their lockdown, they protected their elderly. We didn't do that.
Thank you. Dr. Siddiqui, any comments?
I'll just add one, which is from a data perspective. I think, as Dr. McKenzie said, it would be important to understand what people with disabilities face and to sort of engage with them about their needs. It's also important to understand how this is an axis of vulnerability at the population level and what the kinds of patterns are of things people are facing. And I'll just add that in relation to the earlier question about the infectious disease working group, there is a group. I sort of misspoke because there's two groups happening at our school, and one group led by Kaye Warsame, by Yulika Yoshida Montezuma and others, is looking into socioeconomic issues, and including they may also be able to look at disability.
Thank you. The precautionary principle is the idea that there is a social responsibility to protect the public from exposure to harm, especially with scientific investigation has found a plausible risk. This means starting with the highest level of protections for society and whittling that down as new information about the risks posed or lack thereof comes forward. And we've heard both of you indicated that certain demographics and communities within Canada face greater risks with respect to COVID-19, yet the Public Health Agency of Canada chose not to utilize the precautionary principle in dealing with the virus. Do you feel like if we'd used the precautionary principle, we could have helped to quell the spread of COVID-19 amongst some specific population demographics in Canada?
For me, that's the simplest question I've had all day. Yes, most definitely, Dr. Kitchen. I completely agree with you.
Thank you. Dr. Siddiqui?
Thank you, Dr. Kitchen. A very quick response by Dr. Siddiqui, please.
Just that in some ways, yes, but in some ways, the fundamental issue is the increased risk for exposure, for being out there. So that's an issue as well.
Thank you. We go now to Dr. Jaczek. Dr. Jaczek, please go ahead, 5 minutes.
Thank you very much, Chair. And it's been so refreshing to hear the emphasis from both of you on the social determinants of health as a public health practitioner for so many years, obviously. This is vital, and you've brought it to the fore. And both of you have dug so much deeper within what were originally considered the social determinants of health to dig into the data to certainly analyze much further. Obviously, Dr. Siddiqui, with your emphasis on racialized problems in that community in terms of susceptibility and so on. But my first question is to Dr. McKenzie. Great to see you again, if only virtually. I was wondering if you could tell us a little bit more about the basic income pilot in Ontario. I note that the Wellesley Institute on May 6th did conduct a survey with a number of stakeholders to look at vulnerable people in particular. And one of the most common responses to that survey was in terms of the recovery from COVID-19, potentially the need for a universal basic income. So could you, for the benefit of the committee, tell us a little bit more about your role on the basic income pilot in Ontario that, of course, was terminated after only 1 year, and if there were some learnings in that 1 year time period that were collated and that we could think about going forward.
So I was lucky to be part of the Basic Income Pilot Project as the Research and Evaluation Advisory Group Chair. And so I advised directly the running of the Basic Income Pilot and the link between the Basic Income Pilot and the third-party evaluators who were a consortium of academics. And so in some ways, as you probably remember, I was a translator between the academic language and the bureaucratic language in order to make it work. The fact that the basic income had two different bits. It had a randomized controlled trial in two areas, Hamilton and also in Thunder Bay, which is in the north of Ontario, where people were randomized either to the basic income or not the basic income. And then it had a saturation study in a different place, Lindsay, 22,000 people in a predominantly farming area, to see whether there would be a change in the economy in that area if all low-income people were offered the basic income. And the big effort, and the basic income there was essentially, based on the amount of money you got, it was a tax rebate, which worked very well. So loads of things we learned. One, you can do it. Two, people love it. They find it a much more dignified way of getting their social assistance. Three, entrepreneurs and take risks and build businesses if they have backing and they know that they've got at least a basic income. 4, people change their lives and go back to college, and they get into better housing and give themselves a fundamental chance in order to move forward if they have a basic income. And people move themselves out of poverty if they have a basic income. It was a travesty in my mind that it was stopped. You can't start a research project, say to people that they've got 3 years in order to revolutionize their lives and then take the money away. It's bad for their health. It's bad, obviously, for the country not to have that information. It made us look bad on the world stage because people all over the world were looking for these results. And but when there have been follow-ups of some of those people, in Hamilton there was a follow-up, people who even got 1 year of basic income did better than people who haven't. And so people, I think about time that there are rights and responsibilities from being a citizen, and maybe there has to be a deal with the citizens that they've got rights, and those rights are for a basic level of income which is befitting a high-income country.
Thank you, Dr. Jaksic. We go now to nous allons à ce moment à Monsieur Desilets.
Let's move to Monsieur Desilets. 2.5 minutes, please. Thank you. Thank you, Chair. Dr. Siddiqui. Given unfortunately, Mr. Desilets' microphone isn't functioning. Given the disparity between the black people and the white people, can you explain to us what happens at the moment of birth? You have a phenomenon that you have explained, which this phenomenon that happens at the moment of birth in some countries. Unfortunately, Mr. Desilets' microphone has been disconnected, and he's speaking into his laptop's microphone.
Pardon me, Monsieur Desilets. Stopped your time. If you could just
Regardez, je suis désolé là.
Has it been unplugged? Can you plug it back in if it's, or unplug it and plug it back in? It's working. Just say a couple
C'est
things.
réglé, bon. OK. Ma question s'adresse à Madame Siddiqui.
So here is my question to Dr. Siddiqui, with my apologies for the dysfunctioning microphone.
Is translation being able?
My apologies again. You have referred to inequalities and to wealth disparities between black people and white people. And you have talked about a kind of birth voucher, is it, that you were referring to? Can you please explain the concept?
Yes, thank you very much. So as I mentioned, one of the most unfortunate aspects of inequity is that they start at birth before anyone has a chance to do anything. And that is a result of prior generations having more socioeconomic resources amongst whites and fewer amongst blacks. And in the United States, the disparity in wealth, in family wealth, is tenfold. So if a median white family has $170,000 in wealth, a median black family has more in the order of $17,000. And so in order to combat that, they have talked a lot about strategies that would reduce wealth inequality. And one of those strategies is what they've referred to as baby bonds. And the idea is that you provide children when they are born with a sum of cash that is actually something that can mature over time. So it's not intended as cash to be spent right away. There's many needs that do need immediate attention, but this particular proposal is the idea that you provide a sum that can mature over time and that in adulthood can be used to buy the kinds of things that rich families buy for their kids when they become adults. They often pay for education. They often provide them with down payments for homes. And this kind of a baby bond would function in that same way. And there are economists who have made estimates that suggest that a proposal like this may be able to close the wealth gap in a couple of generations if it were big enough and done well enough.
Thank you, Mr. Desley. We go now to Mr. Davies. Mr. Davies, please go ahead. Sorry, 2.5 minutes.
Thank you. Both of you have, I think, commented on the profound and corrosive impacts of entrenched racial wealth inequality and structural racism. I'm curious what the trend is. Is it staying flat? Are we getting better? Is it getting worse? And second, in my limited time, I'd like each of you, if you were Prime Minister, Dr. Siddiqui, and you were Minister of Finance, Dr. McKenzie, what would be your top 2 priorities for the federal government to start addressing these?
We start with the Prime Minister, don't we?
So thanks very much to both of you. In terms of wealth inequity, it's very difficult to say because we don't have good data. So in the US, I could answer that question for you. In Canada, it's very difficult to say. I can tell you that generally speaking, economic inequity, for example.
Pardon me, Dr. Siddiqui, could you hold your mic, please?
Oh, sorry. Income
Thank you.
inequality is rising. And it's getting worse. And we think that wealth inequality only more so. In fact, we have some evidence that that's the case. The racial divide is very difficult to calculate because we don't have a lot of data. If I were to suggest the top 2 things that we could do in our society, the first would be that we do something to close this wealth gap and to figure out ways in which families can have economic security and economic means to generate education, income, etc. So wealth inequality would be paramount to me. And the second would be it's a tie between income inequality and universalization of many of the services that we know and the programs we know help. Access to education, including post-secondary education, access at the other end to early childhood education and childcare and so on. Let me just say one thing about the basic...
Dr. Siddiqui, I'm sorry, I want Dr. McKenzie to have a crack at his 2 priorities.
So just to start off with, just to say that if you look from the first generation to the second generation to the third generation, the rate of poverty for the Black population of Canada increases. It's the only part of Canada where the poverty rate increases the longer that from people who are immigrants to their grandchildren. And that is a problem. I believe that there are lots of things we can do, but one of the things we have to do is we have to raise the floor. One of the reasons I was interested in social assistance and the basic income and other things like that is to raise the floor so that the gaps between rich and poor are decreased, and that will help racialized populations significantly. But I also think we do need probably to start looking about some sort of more enforceable and sort of legislation with more teeth that starts looking at racial equity. if you look in the Toronto area, the truth is, from studies from the United Way, that racialized population have not had a pay increase in real terms in the last 30 years. And the gap between them and other groups has
Doctor,
increased over up, that please? Time. Oh, yeah. Yes, it's good to say that. I could have gone on forever. And the gaps increased over that time. So we have to decide what we need to put in place to stop that happening.
Thank you.
Thank you, Mr. Davies. And thank you all. And in particular, thank you to the witnesses who have given us such great information. And thank you for sharing your time with us today. And with that, we will suspend and we will bring in a second panel. So thank you all very much. Bye-bye.
Thank you all.
Welcome back to meeting number 32 of the House of Commons Standing Committee on Health. We're operating pursuant to the order of reference of May 26, 2020. The committee is resuming its briefing on the Canadian response to the outbreak of the coronavirus. I would like to make a few comments for the benefit of new witnesses. Before speaking, please wait until recognized. When you are ready to speak, you can click on the microphone icon to activate your mic. A reminder that all comments should be addressed to the chair. And interpretation in this video conference will work very much like in a regular committee meeting. You have the choice at the bottom of your screen of either Floor, English, or French. And as the clerk just mentioned to you, if you plan to speak in, if you plan to alternate from one language to the other, you will need also to switch the interpretation channel so that it aligns with the language you are speaking. And you may want to allow for a very short pause when switching languages. When you're not speaking, your mic should be on mute. So I would like to welcome our witnesses. We have from the Canadian Institute for Health Information, CIHI, Ms. Kathleen Morris, Vice President, Research and Analysis, Ms. Melanie Jose Davidson, Director, Health System Performance. From the Department of Public Safety and Emergency Preparedness, the RCMP and the Communications Security Establishment, We have Ms. Colleen Merchant from Public Safety, Director General, National Cybersecurity, National and Cybersecurity Branch. We have Mr. Scott Jones, CSE, Head of Canadian Centre for Cybersecurity, who is, and also Mark Flynn, Mr. Mark Flynn from the RCMP, Director General, Financial Crime and Cybercrime, and Federal Policing Criminal Operations. From Statistics Canada, we have Ms. Karen Milhorian, Director General, Social Data Insights, Integration and Innovation. We have Mr. Marc Lachance, Acting Director General, Diversity and Populations, and Mr. Jeff Latimer, Director General and Strategic Advisor for Health Data. Thank you all for being here. We will start with our statements from witnesses. We'll start with the Canadian Institute for Health Information. Please go ahead. You have 10 minutes, please.
Thank you, Mr. Chair. On behalf of the Canadian Institute for Health Information, thank you for the opportunity to be here to appear before the Standing Committee. I am speaking to you today from the traditional territory of the Wendat, the Anishinaabe First Nation, the Haudenosaunee Confederacy, and the Mississauga of the New Credit. I recognize that this land is now the home of many First Nations, Inuit, and Métis people. Since 1994, CIHI, as we're usually called, has been a leader in health data and information. CIHI is a not-for-profit independent body funded by federal government and all provinces and territories. Our board of directors is made up of deputy ministers of health and other health system leaders representing all regions of the country. CIHI has signed data sharing agreements with every province and territory and several federal organizations. Pan-Canadian health data is a shared responsibility between ourselves and our partners at Statistics Canada, Health Canada, and the Public Health Agency. Each organization has a defined role within the health ecosystem, with CIHI's focus on healthcare systems and their functioning. For example, CIHI oversees data on hospitals and long-term care, health spending and workforce, and information on health system performance. Data is provided to us voluntarily by the provinces and territories. This allows the data to be aggregated and compared and for health systems to learn from each other. We also work closely with organizations that are international, such as the OECD and the Commonwealth Fund, which enables us to learn from other countries. CIHI makes the data and information available to policymakers, health system leaders, researchers, and the public. Although we play an integral role in providing relevant and reliable data and analysis to policymakers, we are neutral and objective in fulfilling our mandate. We neither create nor take positions on policy. Ultimately, we work to help improve the healthcare system and the health of Canadians. Maintaining public trust is critical to our success. We're committed to protecting the privacy of Canadians and ensuring the security of their personal health information. During COVID-19, CIHI's work has focused on three main priorities: maintaining the current data supply and looking for opportunities to improve. Number two, developing analytical products or services that assist with the COVID response. And thirdly, to provide data and information quickly to those who need it. Let me share one or two examples in each of those three priority areas. In terms of maintaining and enhancing the data supply, we work closely with our data suppliers to mitigate disruptions to the data. We are pleased to report that hospitals and the majority of long-term care homes were able to complete data collection for the 1920 fiscal year within the normal deadlines. We also shared new standards to capture confirmed and suspected COVID cases in care facilities. This information will be critical as we look back at how our hospitals responded to the pandemic. We also created guidelines for race-based data collection in health in an effort to facilitate the collection of high-quality data, which I know was a focus of your earlier discussions. The second goal is around providing analysis to support decision-making. During the early phases of the pandemic, we received many requests from those who were trying to project the need for hospital beds, staff, and supplies, such as ventilators and personal protective equipment. In response, we developed a tool to help those who are modeling and be able to deliver results at a local level. We also provided advice and facilitated the exchange of information between modeling teams working in different parts of the country. Most recently, we released a report that looked at Canada's pandemic experience in long-term care compared to that of other countries. The report found that early adoption of strict public health measures in long-term care was associated with fewer cases of COVID-19 and lower death rates. Finally, our third initiative was around responding to requests. In addition, over the past few months, CIHI has responded to more than 500 requests for information and data. The topics of these requests have changed over the weeks. Initially, they were very focused on describing the situation, how many cases, how many patients, how many hospitalizations. As time went on, I had more questions around long-term care, and most recently, the questions have focused on the reopening of the health system, ensuring that that's done safely, and the potential consequences of the shutdown on issues like mental health and substance use and planned surgeries. As we navigated the pandemic, working closely with our federal partners, it has become apparent that there are several gaps in important data flows within and between healthcare systems in Canada. COVID-19 has highlighted some of these gaps, and we see them falling into one or more of three categories. The first is gaps in data availability. That is, it's a real gap. The data simply doesn't exist, like the panelists in the first half of this session may have highlighted. The gaps here include information on supplies and equipment available in the system, or they could be gaps around the characteristics of long-term care homes, such as the number of patients to a room, the ownership models, and the staffing ratios. We also saw significant gaps when we tried to examine some parts of the health workforce, such as the number of personal support workers and where they worked. The second nature of gap is where the data exists, but it can't be accessed quickly enough to support decision-making. For example, we needed more timely hospital data and emergency room data. This data is collected from hospitals across the country, but does not flow in quickly enough to support pandemic-type decisions. To temporarily fill this gap and help the federal government understand whether hospitals were becoming overwhelmed with COVID cases, we created a dashboard report on the supply and use of hospital beds, ICU beds, and ventilators. This report is updated manually on a daily basis by key contacts in the provinces and territories, as well as CIHI staff. Finally, some gaps exist because we can't integrate data. Information systems often can't speak to each other, sometimes because they use different standards, and sometimes because the data doesn't include personal identifiers that allow this connection. For example, right now we can't follow a patient's full COVID experience from testing and through to treatment and hopefully recovery, all because the public health electronic medical records and health system records are fragmented. CIHI is always working to enhance the scope and availability of Canada's health system data for analysis and decision-making. While there's many gaps, we recommend focusing on three. First, comprehensive, timely, and integrated health workforce data to support planning and policy. The collection and analysis of health workforce data is fragmented and incomplete today. We need to capture additional professions in our current systems, such as respiratory technicians and personal support workers, to better understand both the mix of staff who provide frontline care and where they work. We also need to make sure that this data is linkable to data on the use of health services and to financial data systems. This could help identify infection rates in the health workforce, the use of overtime, and longer-term effects of COVID-19 on frontline workers. The second area is more complete and timely data on long-term care homes, the residents, workforce, and facilities. While there's excellent information on the clinical profile of long-term care residents in most parts of the country, there are some significant gaps. We have little information about the residents' quality of life and care experiences before COVID, or how these might have changed during the pandemic. We also have limited information about the facilities themselves, about the mix of staff who provide care, and on how infectious outbreaks are dealt with. It's important to recognize that while long-term care treats our most vulnerable seniors, Many older Canadians live in a variety of different group care settings for which we have very little information. Finally, more timely and comprehensive data on hospital-based care and clinic services, both for COVID patients and for patients with other health conditions. CIHI's hospital data provides deep insight into the number of Canadians treated and the type of care they receive. But this high-quality data is assembled by health information specialists after a patient is discharged from the hospital. To better manage our systems when they're facing emerging issues like COVID-19, but also seasonal flu or the opioid crisis, we need to automate the flow of hospital data in real or near real time and have more information on patients when they're admitted. Discussions around these actionable solutions are underway. The groundwork is there, but these solutions require the engagement of health system managers and healthcare providers, leadership from policymakers, and funding for the development and implementation of information systems. What we ask today is for your commitment and support. Better data allows for better decisions and ultimately healthier Canadians. Thank you for the opportunity to present, and I'd be pleased to answer any questions.
Thank you. And we go now to Department of Public Safety, Emergency Preparedness, RCMP, Communication Security Establishment. I believe Mr. Jones is going to start. Please go ahead for a 10-minute statement, please.
Well, good afternoon, and thank you, Mr. Chair and committee members, and thank you for the invitation to appear today to discuss cybersecurity during the COVID-19 pandemic. As mentioned, I'm Scott Jones, and I'm the head of the Canadian Centre for Cybersecurity at the Communication Security Establishment. And I'm very pleased to be joined by my colleagues, Chief Superintendent Mark Flynn, Director General of Financial Crime and Cybercrime from the RCMP, and Colleen Merchant, Director General of National Cybersecurity from the Department of Public Safety. Our departments have distinct but complementary mandates as they relate to cybersecurity. CSE, reporting to the Minister of National Defence, is one of Canada's key intelligence agencies and the country's lead technical authority for cybersecurity. The Canadian Centre for Cybersecurity, or as I'll refer to it from now on, the Cyber Centre, is a branch within CSE. We defend the Government of Canada, we share best practices to prevent compromises, we manage and coordinate incidents of national importance, and we work to secure a digital Canada. Public Safety leads the Government of Canada's cybersecurity policy work. This involves the implementation of the 2018 National Cybersecurity Strategy and the coordination of government-wide efforts to help secure digital and cyber assets through strategic level initiatives. Public Safety also supports critical infrastructure protection and offers assessment tools to provide expert advice to owners and operators on how to improve their cybersecurity and cyber resilience posture. RCMP Federal Policing is responsible for the investigation of attacks against Canada's critical infrastructure, which includes the healthcare sector, in collaboration with the police of local jurisdiction. Additionally, the RCMP has its National Cybercrime Coordination Unit, which is a national police service that coordinates the response of Canadian police agencies to cybercrime incidents. Together, our three departments work with the greater Canadian cybersecurity community to protect Canada and Canadians from potential cyber threats. Today, I would like to provide an update on what the current cyber threat environment looks like in the COVID-19 pandemic, and also highlight the important work that CSE, the RCMP, and Public Safety are doing to protect the Government of Canada and Canadians, specifically in the context of the health sector. Cyber threat actors are attempting to take advantage of Canadians' heightened levels of concerns around COVID-19. Prior to and amplified by the pandemic, our lives are becoming increasingly reliant on digital communication. Cyber criminals are aware of this digital reliance and are seeking to take advantage of the current situation. More than ever, collaboration for cybersecurity is critical, whether it is for the cyber infrastructure underlying Internet of Things connected devices, or for the applications supporting digital exposure notification. Designing solutions with cybersecurity in mind is a condition for long-term success. From a government perspective, the underlying objective must be to protect Canadians online. These efforts are underway and they are significant, with the Cyber Centre as the lead for the federal government. Among these efforts, cybersecurity and cybercrime remain interconnected and remind us of the importance of pursuing those responsible through the criminal justice system. Law enforcement remains a critical element of cybersecurity. As such, the RCMP Federal Policing Program investigates the most significant threats to Canada's political, economic, and social integrity, including cybercrime that targets the federal government, threatens Canada's critical infrastructure and the healthcare sector,
involves the use of cyber systems to facilitate or support terrorist activity, and threatens key business assets with high economic impact. The RCMP works with domestic and international law enforcement partners and with other GC agencies or Government of Canada agencies to ensure that the wide array of cyber threats are not treated in isolation. Appropriate and timely information sharing is essential for investigation, which in turn contributes to improved cybersecurity for Canadians. For example, the Cyber Centre and the RCMP work together by sharing information about scams to warn Canadians and share indicators of compromise so they can be blocked and prevented. From a public safety perspective, they tackle these questions by engaging with stakeholders and fostering good discussions to identify problems and propose policy solutions. The Cyber Centre is working tirelessly to raise public awareness of cyber threats to health organizations by proactively issuing cyber threat alerts and providing tailored advice to the health sector, government partners, and industry stakeholders. Throughout COVID-19, the Cyber Centre has worked closely with industry and commercial partners to facilitate the removal of malicious websites, including those that have spoofed Canadian government departments and agencies. The Cyber Centre has also helped monitor and protect important Government of Canada programs against cyber threats, including the Canada Emergency Response Benefit web application. We've continued to evaluate cloud applications, including for the Public Health Agency, and enabled cybersecurity monitoring and defense for cloud usage across the government. Individual Canadians, however, are also at risk. And as people and organizations shift to working and learning from home, personal devices and home networks have become attractive targets. In response, the Cyber Centre has partnered with the Canadian Internet Registration Authority, or CIRA, to create and launch the CIRA Canadian Shield, a free DNS firewall service which provides online privacy and security to all Canadians and for free. The Cyber Centre has also collaborated with the Canadian Anti-Fraud Centre, operated by the RCMP, the Ontario Provincial Police, and the Competition Bureau, who are Canada's trusted sources for reporting and mitigating mass marketing fraud. The Anti-Fraud Centre's primary goals are prevention through education and awareness, disruption of criminal activities, and dissemination of intelligence, which enables law enforcement to identify organized crime involvement in fraud schemes. Through targeted advice and guidance, the Cyber Centre is helping to protect Canadian cybersecurity interests, and I encourage all Canadians to visit getcybersafe.gc.ca and all businesses to visit cyber.gc.ca to learn more about our best practices that can be applied to protect you and all Canadians from cyber threats. Finally, the Cyber Centre has assessed that the COVID-19 pandemic presents an elevated level of risk to the cybersecurity of Canadian health organizations involved in the response to the pandemic. Cyber threat actors know that the health sector is under intense pressure to slow the spread of COVID-19 and producing medical treatments to prevent new infections and the spread. Hospitals and other frontline medical services are often vulnerable to malicious cyber threat activity due to limited cybersecurity capacity. We continue to recommend that Canadian health organizations remain extra vigilant and take the time to ensure that they are applying cyber defense best practices, including increased monitoring of network logs, reminding employees to be alert to suspicious emails, use secure teleworking practices where applicable, and ensuring that servers and critical systems are patched for all known security vulnerabilities. To further protect the health sector, public safety, in close collaboration with the Cyber Centre, is developing a Canadian cyber survey tool to provide health sector organizations, such as hospitals, doctors' offices, and long-term care facilities, amongst others, with an easy-to-use tool to assess the cybersecurity of their organization. The survey can be completed in less than an hour and is completely voluntary and will be used for two main purposes. First, to provide the organization with a report detailing any technical and cybersecurity program-related findings that should and could be addressed to enhance their cybersecurity. And second, to identify cybersecurity trends and common challenges in the health sector to help tailor cybersecurity engagements by the Government of Canada to strengthen the cybersecurity posture of the health sector as a whole. Public Safety is aiming to launch this survey tool in the coming weeks and will broaden the application of this tool to all 10 critical infrastructure sectors to examine the cybersecurity of all aspects of supply chains. It should also be noted that the RCMP's National Critical Infrastructure Team has worked with the Public Health Agency of Canada to share awareness material within the health sector. In addition, they have divisions across the country to continue to develop new partnerships within the health sector, increasing those organizations' situation awareness of the potential threat landscape. Together, our three departments would like to note that even when all of the possible precautions are taken, if a compromise occurs, it is critical that organizations inform us of any cyber incident they experience. Cybersecurity is everyone's responsibility, and it will take all of our expertise and collaboration to protect Canada and Canadians. The more we share, the better protected we will all be. If we don't share, the next person who gets hit will be the next victim. And thank you for the invitation to appear before you today. We will be happy to answer any questions you may have.
Sorry, StatsCan, please go ahead. We have you have 10 minutes for an opening statement.
Thank you very much, Mr. Chair. I want to thank you for the opportunity to appear before your committee as a representative of Statistics Canada. As a public servant, I'm always grateful for these opportunities. So I'm here with my colleagues Karen Morin and Marc Lachance. They will answer questions within their area of expertise if required. It's clear to us that the pandemic has raised significant concerns about the disproportionate impacts across Canada based upon socioeconomic differences. Not all groups have been equally affected, and we have observed such impacts within our data, particularly among seniors living in long-term care facilities, healthcare workers, racialized communities, Indigenous communities, and those living in low-income households. Before presenting a few key examples, it's important to highlight the data collection accountabilities related to COVID-19. As you probably know, the provincial and territorial public health authorities are responsible for collecting and reporting within their jurisdiction COVID-19 cases. The Public Health Agency of Canada is responsible for receiving these data from the provinces and territories and reporting at the national level. And while Statistics Canada does not collect COVID-19 data directly, we do provide expertise and advice on gaps in existing data, potential strategies to address such gaps, as well as data collection and data exchange standards. I'd like to make one last point related to data collection before I provide examples. There are generally two methods: survey data, where we sample the population, and administrative data, where we typically have a census of all cases. COVID-19 data are collected through administrative data, which often have a number of limitations.
Pardon me, Mr. Latimer, could you hold your mic, please?
Thank you very much. So we have a number of limitations, and in Canada, it is clear that these data limitations are creating significant challenges. First, there's a lack of common data standards and data exchange standards across the country, along with inefficient data processing and data quality concerns. Second, the lack of granularity in the data that is collected related to COVID-19 makes it difficult to answer key policy questions. For example, there are no data collected on demographic characteristics, such as race, ethnicity, or income, nor are there data on an individual's underlying health status. In addition, detailed geospatial data are not available to better understand the spread of COVID-19. And lastly, and I think most importantly, the data submitted to the federal government does not include identifiers that could facilitate safe and appropriate record linkage with existing Statistics Canada data sets that could potentially fill these gaps. But that being said, we have been actively collecting new survey data and analyzing our existing data to shed some light on the potential indirect impacts of COVID-19. During this time of social distancing, for example, 64% of youth are reporting substantial declines in their mental health status, compared to only 35% of seniors. The unemployment rate for students in May of this year was 40%, which is triple the rate reported last year in the same month. A similar pattern was evident amongst non-student youth as well. More than 70% of seniors in Canada over the age of 80 report at least one pre-existing chronic condition related to severe symptoms of COVID-19, which is more than double the rate among adults under 60. If we look at the immigrant population, employment losses during COVID-19 have been more than double compared to the Canadian-born population. We also know that before COVID-19, Black Canadians were already experiencing unemployment rates twice that of the general population. And the wage gap between these groups has been widening in recent years. And among Black youth, almost twice as many report experiencing food insecurity compared to other young Canadians. Visible minority populations, such as Chinese and Korean Canadians, have reported increases in race-based negative incidents over the last few months. And 1 in 10 women have reported being concerned about violence in their home during the pandemic. If we examine the socio-demographic characteristics of long-term care workers who are currently facing some of the most difficult challenges, they are more likely to be immigrants. They are less likely to work full-time, and they are more likely to earn less than the average Canadian. Indigenous men are 2.5 times more likely to be unemployed, and they earn on average 23% less than their non-Indigenous counterparts. In almost all indicators, including health status and life expectancy, the Indigenous population lags well behind Canadian averages. The pandemic has shown glaring light on many of these pre-existing social inequities that Statistics Canada has been tracking for decades. In order to respond to the need for more data, we have launched a number of rapid data collection vehicles, such as web panels and crowdsourcing surveys. The topics have included the impacts of COVID-19 on labor, food insecurity, mental health, perceptions of safety, trust in others, as well as parenting concerns. Statistics Canada finished collection just yesterday using our crowdsourcing surveys to better understand the impact on persons with long-term disabilities. These data will be available in early August, and they will include information on visible minority status, as well as other demographic markers such as gender, immigrant status, and Indigenous identity. More data on mental health issues will also be made available in the coming weeks. These will provide breakdowns by gender diversity, immigrant status, as well as ethnocultural groups. In partnership with the provinces and territories, we have also significantly increased the timeliness of death data in Canada so that a clear picture of excess death during the pandemic can be estimated. We will be releasing these data publicly next month. We are also partnering with the Canadian Institute for Health Information to examine in greater detail the issues among healthcare workers and long-term care facilities. Finally, we are working with the Public Health Agency of Canada to make detailed preliminary data on the number of confirmed COVID-19 cases available to Canadians and researchers. I'd like to thank you very much for your time. My colleagues and I are available to answer any questions you may have. Thank you, Mr. Chair.
Thank you. Thank you all to the witnesses for the statements. We will start our rounds of questioning. We will undertake to do 2 rounds. However, we are going to be short of time, so we're going to cut down. Starting in the first round, we're going to go to 5-minute time slots instead of 6. And we will start with Ms. Jansen. Ms. Jansen, please go ahead, 5 minutes.
Yes, thank you very much. I wonder if I might be able to begin my questions with Ms. Marchant. I have a question in regards to an issue that's had a bit of news. On March 31st, 2019, Canada's National Microbiology Lab sent 15 strains of Ebola and Henipa viruses to the Wuhan Institute of Virology for the purpose of gain-of-function experiments. Now, gain-of-function experiments are when a pathogen is intentionally mutated for the purpose of seeing if it's more deadly or infectious. An ATIP was recently released, which gave us some of the details of that transfer of those viruses to the Wuhan lab, but most of the important information was missing. Now, since the government has stated repeatedly how they're committed to a whole-of-government approach to pathogen security, can you explain what part your department played in the investigation of this breach?
The question was directed to me?
Yes, Ms. Marchant. I'm understanding that wondering about the pathogen security whole of government approach. Can you explain what part your department would have played in investigating this breach?
That's something that I would not be able to answer. It sounds like it was not a cybersecurity issue. So I would be happy to go back and see if someone else in the department would be able to answer that question.
Is there possibly anybody else on the panel that might have some information in regards to that breach?
That I don't think so. Scott and Mark from the RCMP, they would not have information on that either.
Okay, so we know that in 2014, China conducted a significant cyber attack against the NRC. And despite this history, the NRC has partnered with a company connected to the Chinese regime, CanSino, to produce a test, a vaccine in Canada. Sorry, to produce a vaccine in Canada. Are you concerned about this at all?
From a cybersecurity standpoint, we're very concerned whenever there's an issue with the vulnerabilities in any of the information that may be transferred between organizations. From a telecommunications or from a computer security aspect, we're always concerned, whether it's from here to another country or even within Canada. So in order to secure the infrastructure, that's where Scott Jones and his organization come in with the Cyber Center in providing the best advice and guidance to organizations such as the NRC.
So Scott, well, I'm just wondering, is your department monitoring the situation right now in regards to the work that's being done with CanSino?
Public safety would not be monitoring that. That would be something that would be more monitored, I would say, from a cybersecurity perspective by the Cyber Center or some of our security and intelligence colleagues. But from a strategic policy point of view, which is where public safety fits in, that's not something that we're monitoring closely.
So it would not be your department that would discover whether inappropriate cyber interactions were happening between, say, that Dr. Chu, and the team at the Wuhan Institute of Virology?
No, it would not be. That's more in the security and intelligence area.
Okay. So then I think I'll move on to Statistics Canada. Mr. Latimer, following the SARS outbreak in early 2003, IBM produced an IT system for the Public Health Agency of Canada called Panorama. Now, it was meant to ensure we had a comprehensive national communicable disease outbreak management system. This program was developed by IBM, the creator of our infamous Phoenix Pay system. And in August 2015, the Auditor General of BC, where I'm from, found that the program was prone to errors, slow to function, and susceptible to unexpected system outages. It was basically a complete disaster that cost BC taxpayers alone the ridiculous sum of $113 million, which was 420% more than originally quoted. Are you familiar with this program and how it functioned?
Thank you for the question. I'm not familiar with this program as it's a public health agency accountability, so I would not be able to comment on that. I can comment on the current data situation in Canada, but not on that system.
Okay, so
18 seconds, please.
What I was wondering is how much of a problem is it getting national data collection programs together due to the inability of getting provincial buy-in, or is it just, I was told that in 2 weeks, StatsCan could come up with one of these live systems that could be used for this purpose?
I'm not convinced that 2 weeks would be appropriate, but I do think that we have the expertise and the experience to help the country develop national data standards and data exchange standards, yes.
Thank you,
so
Ms. Jansen.
you could come up with something.
Thank you, Ms. Jansen. We go now to Mr. Fisher. Mr. Fisher, please go ahead. 5 minutes.
Thank you very much, Mr. Chair, and thank you all for being here today. I guess my first question would be for the communications security establishment folks. We're hearing about coronavirus scams and phishing. Just this week, we're hearing about seniors that are getting calls about the top up the COVID-19 assistance from the government on OAS and GIS, asking for information to access their bank accounts in order to deposit this money. When of course they don't have to apply for this money. How does your organization work with the RCMP or I guess local police forces to investigate something like this? Also, possibly, how do you work to ensure that the public is aware of these? I mean, we put it on our Facebook today and it's been shared over 300 times.
Well, thank you for the question, Mr. Chair. And there's actually many different ways that we're working to deal with this. And maybe Chief Superintendent Flynn would like to jump in as well from the RCMP perspective. The first thing is that anything that looks like it's impersonating the government of Canada, we've been very active on trying to make sure that we're protecting both the brand and the integrity. So taking those offline very quickly. to the point where a lot of times it's happening before Canadians can fall victim. The second one, though, is we also are sharing a lot of information so that it is blocked. So something like if it is a email-based scam, something where you're going to click, getting you to do something, something like a Xera Canadian Shield actually has those blocked. So Canadians would be protected if they use this free service that has been stood up. The third way is we are working with the RCMP, the Canadian Anti-Fraud Centre, as I mentioned in the opening remarks, also to get information out there so Canadians are aware. And unfortunately, COVID is this is a particularly good lure to get people to click and get people to share information. And so that's why we've been putting out a lot of information, threat assessments, threat bulletins, etc. as well.
Thank you for that. I guess to the folks at CIHI, we were all shocked in this committee, and we've heard lots about this, and Nova Scotia has been hit just as hard. Finding out that 4 of every 5 deaths from coronavirus are residents or were residents of long-term care. What kind of measures do you believe that the provinces and territories should implement in long-term care? And I guess I know you folks touched on this a little bit during your opening remarks, but how are other countries tackling this problem?
Mm-hmm. Thank you very much for the question, Mr. Chair. So you're correct that CIHI did actually share some information quite recently about how the long-term care sector in the country had been quite hard hit. Overall, looking across all age groups, Canada's death rate from COVID has actually been lower than an international average, but the incidence in long-term care has definitely stood out as one of the highest. One of the things that we learned from that work was that countries that had implemented some specific measures targeted at the long-term care sector at the same time as they put in their broader shutdown measures really had many fewer COVID infections and deaths in long-term care. So some of the things that might be included in long-term care specific measures would be around broad testing for residents of long-term care facilities and repeated testing. There'd be isolation wards potentially to make sure that if one of the residents became ill, that there was a way to separate that resident from others to reduce infection. As well, one of the important parts is around having the right kinds of supports for long-term care workers, being able to help with surge staffing. For example, when the caseload became greater, and in Canada's case, the Army was involved in some provinces, having specialized teams who are trained in this and having personal protective equipment freely available so that all of the long-term care workers felt secure. So those are some of the measures that we've seen in other countries that had lower death rates in long-term care.
But higher death rates possibly across the board, just lower in long-term care.
That's correct.
Yeah. StatsCan folks, thank you for being here. Tell me a little bit about how StatsCan is changing from what they normally would do and going above and beyond because of this new normal and the impacts that we're facing with COVID-19.
Thank you for the question, Mr. Chair. I think in my opening remarks, I've highlighted a few. I'll repeat them and add a few, I think, which is really important. First and foremost, we have been implementing significantly new data collection methods that are highly rapid, quite rapid. So, for example, our web panels and our crowdsourcing surveys, while they don't, they're not the same as our full representative surveys across the country. They are providing significant and new information in a very rapid time frame, and I think that's a critical step forward. We're still relying, and we need to rely on our national statistics program, but these are an interesting and important addition. We've also been working with the provinces to speed up the collection and reporting of death data in Canada, and that's a critical piece. It used to be 2 years almost between the fact of the death and the reporting, and now we are planning on releasing monthly reports. We are working with the provinces and territories. We're hoping to have as much coverage as we can on a monthly basis, and those will be starting next month. And I think that's a massive increase, and I think an important one for Canada to start to see the death data move forward like that. Those are two, I think, that are really important. We are working in a number of other areas. Disaggregation of data is a critical piece that we're really working hard to try and make the data available at the level that's required to make significant policy decisions. So I think those are three that I would highlight. Thank you.
Thank you,
Mr.
Chair.
Fisher.
Thank you, Mr. Chair.
C'est maintenant Monsieur Desilets.
Now, Mr. Desilets, go ahead. 5 minutes. Thank you, Mr. Chair. And thank you to all the witnesses. Thank you for being here and to share your knowledge with us. My first question for Mr. Latimer. We heard at this standing committee many times, many witnesses have told us all the major issues. It's been very difficult to make available data, and collecting of data, sharing of data has been difficult. And this has been between the provinces and the federal government. And there have been many issues. Today, earlier, we heard about Kai-Hai. They shared the same concerns. Earlier, we spoke with Dr. McKenzie. We heard these same things, and many witnesses have testified to this. Mr. Latimer, on one hand, do you agree with this observation that I'm making?
Merci beaucoup pour la question. Thank you very much for the question. I would agree that there are significant issues in the way in which COVID-19 data is collected in the jurisdictions and reported federally. So I've highlighted a couple in my opening remarks. There really are no common data standards and data exchange standards across the country. I think that is a significant issue. The level of detail that is collected does not provide the important demographic breakdowns that would be required. And I think the issue of not having personal identifiers at the federal level, which prevents linkage, and which is a significant savings and a way in which we can fill in data gaps through record linkage with our existing data holdings, is also not available. So yes, I would agree.
How do you explain that in a country like ours, we don't have a plan or an integrated plan? Because we well know that when there is a pandemic like the one we are living right now, information is key. South Korea, in 24 hours, was able to implement a system that gave very precise directives. So how is it possible that we have that in our country? I do not understand why we don't have an integrated plan to share information. It's essential.
Merci beaucoup. Thank you very much for the question, Mr. Chair. I do not want to speak on behalf of my colleagues at the Public Health Agency of Canada, but I will say that they are working on a strategy, and we are collaborating with them every single day, working closely to help develop a national strategy that would address all of these issues that I've highlighted. Thank you, Mr. Chair.
So should I understand, Mr. Latimer, that the responsibility should be the responsibility of Public Health Canada? Is it PHAC that should manage, supervise, control all these informations that are essential?
Thank you for the question, Mr. Chair. I would not be comfortable. I think that's well above my decision-making authority to decide who in Canada should be collecting these data. I will say that both organizations have the expertise, and we are working collaboratively to fill in the gaps.
So what's the other organization? So I'm talking about Public Health Canada. What's the other one?
I was talking about the Public Health Agency of Canada and Statistics Canada, and we are working collaboratively with Health Canada as well. All three. Merci.
Merci beaucoup, Monsieur Latimer.
Thank you very much, Mr. Latimer. Do I still have time, Mr. Chair?
30 seconds.
Bon, on y va rapidement.
So very quickly, Ms. Scott. Mr. Jones. 2 weeks ago, we asked the government to implement a way of doing so that digital services are safe from the beginning. Do you believe this is realistic?
Mr. Chair, thank you for the question. I think it's very important. As I mentioned in my opening statement, cybersecurity designed from the start and understanding what threats could be faced. Unfortunately, we always look at typically when we look at an application, we look at the benefits. We also need to look at how it can be misused from a cybersecurity perspective. And I think we've made a lot of strides, certainly in the exposure notification system. We're part of the team that's working on this to make sure that it is ready from the start and designed with cybersecurity in mind. And we want to be part, and it's important that we continue to reinforce this, that it's not just the benefits of the technology, we have to look at how it can be misused.
Merci, Mr. Jones.
Thank you, Mr. Jones.
Monsieur Desilets.
Thank you, Mr. Desilets.
Mr. Davies. Mr. Davies, please go ahead, 5 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for being here. Ms. Morris, first to you. Does CIHI currently collect national information regarding the availability of healthcare system resources such as ventilators, intensive care units, and hospital beds?
Thank you for the question. We do collect that information and in fact have quite detailed information on the patients who would be using these services. One of the challenges is it flows a little bit more slowly because it's based on discharge data. So it's not as available as quickly as we might like during a pandemic situation. One of the things that we've done to address this is to pull together data very quickly, working with the provinces and territories to create a dashboard that looks at the supply of beds, ICU beds, and ventilators, the number of COVID patients that are using these resources, and the number of people with other health concerns who need that type of care. We put that together and update it daily.
Thank you. Do all provincial and territorial governments now provide CIHI with that information?
Yes, there's a few small gaps, but in general, we're getting good data flows as reasonable from the provinces and territories.
Thank you. Could you undertake to provide this committee with the list of that information? I'm curious, for instance, if we have a total of how many ventilators, for instance, we have available in Canada, particularly if we do face a second wave in the fall. Is that something you could provide the committee?
I believe that would be possible, and I will take a look at the numbers change daily, but we'll try to endeavor to bring you some of that information after the meeting.
Thank you. Now, in response to calls for better demographic data to understand health inequities and COVID-19, in May, CIHI released an interim race data standard intended for use by any jurisdictional organization that decides to collect this kind of data. However, as you probably heard in the first panel and after that, many advocates have criticized this approach because it's voluntary. And they say the federal government has a leadership role to play to ensure there's consistent pan-Canadian data, regardless of jurisdiction. Since the current gap in information makes it impossible to target resources and care where they're most needed, should the federal government impose mandatory national standards with respect to the collection and sharing of socio-demographic data related to COVID-19?
Thank you for the question. We believe that having as much detailed data available as possible is critical to understanding and planning and managing health services. We've worked for quite a long time with affected communities to develop what we call our equity standards. So those talk about income, sex, gender, a number of things, and include race and Indigenous status. They are important to really understand and plan services. One of the things that we've learned through this is that while collecting the data is important, it's also very important for the communities about who generate the data or about whom the data is about are comfortable and collaborators in the data collection. In many cases, there are racialized groups particularly who believe that data collection has been used for purposes that have created difficulties and problems for them. We believe that attitude is changing and that the benefit of data is clear. And our role with this is to provide the standards so that it's collected in a comparable and clear way and can be aggregated for good use.
Thank you, Mr. Latimer. To you, you've identified one of the gaps being a lack of common data standards in national. Do you also think that there should be national mandatory reporting with respect to demographic information, like on race and ethnicity? And I would comment and note that we do know, and we heard in the previous panel, that in our census we do. Stats Canada does give a sample of 100,000 people who are typically asked about those questions. Is it time to make that apply to everybody?
Thank you very much for the question. I'm going to turn to my colleague, Marc Lachance, who has the expertise to answer that question for you.
Sure.
Yes, good afternoon. So I hope you can hear me well. So this is a very good question. So as for similar to our colleague from Kai, so StatsCan is producing national standards. As you mentioned, the census is one of the major data collections activities on which we apply those standards. All those standards that Statistics Canada make available as a national statistical organization are being, we develop them with communities, with experts. We also test it with the respondents to ensure that they are understanding those standards. So we have standards that we can make available to other organizations. They're all available publicly. As I mentioned, they are being trusted and used. We also working closely with our
With respect, Mr. Lachance, the question is whether or not you would make it mandatory so that all Canadians are asked about race and ethnicity instead of only 100,000. That's the question I'm asking.
So I don't think I understand the question about the 100,000. So as we know, the census, we do ask those questions to a certain ratio of the populations. So there's the standards relating to ethnicity or ethnic origins. We also have the visible minority questions. So those are the questions that are asked to the census, but also to other surveys. So Statistics Canada doesn't have the mandate to force, those standards. What we have is that we applying those standards to our surveys to ensure compatibility among our surveys, as well as the census and other population surveys that we are administrating, including the health surveys.
Thank you, Mr. Davies.
Thank you.
So that ends round one. We will start round two now. We're going to cut back time on this round as well. The 5-minute slots will go to 4 minutes. The 2.5-minute slots, unfortunately, will have to go to 2 minutes. So we will start this round with Mr. Weber. Mr. Weber, please go ahead. 4 minutes.
Thank you, Mr. Chair. 4 minutes. Oh boy. My first question to StatsCan, Mr. Latimer. Mr. Latimer, you brought up the collection of death data that you guys are doing there, the collection of COVID-19 deaths. I want to know whether or not you are collecting death data on non-COVID deaths due to cancellations of elective surgeries such as heart procedures or cancer treatment because of the response to this pandemic.
Thank you for the question. We are collecting data on all deaths in Canada, not just COVID-19. And so the monthly death reporting that we're planning on starting next month will include all deaths that are reported to us from the provinces and territories. We would not be able to make a determination as to whether those deaths were the result of something, but other analysts may be able to look at those questions.
Thank you for that. Mr. Jones at Cyber Center, almost overnight and without warning, industry and government went home to work during this pandemic, and we adopted things like Zoom overnight, as we did here. Now, there is much talk about the government employees working from home in the future as well. Many of these employees have access to state secrets, military information, and personal information. So how would you recommend that we balance the risks between personal safety and security and national safety and security?
Well, thank you for the question, Mr. Chair. And I think there's actually a lot of important elements. First is we do have advice and guidance for Canadians that are working from home, things that they can do. So you can use Zoom, for example, as we are right now, in a way that's a lot more secure. So lobbies, waiting rooms, passcodes and things like that, so that you can't be Zoom bombed, the tool at the time, things like that. But from working from home, there are a lot of things that can be done to make yourself more secure. Canadian Shield is one of those for every Canadian. From a government-specific aspect, though, we do work with our colleagues at Shared Services Canada and Treasury Board. For example, I use a government-furnished device. It is managed very carefully. I do not have administrative privileges. We do have defensive monitoring, and it works through the government network. So even though I'm using my home Wi-Fi, I am not connected directly to the internet. I connect back into the government through a secure network. And for the national security side of things, that's also one of our responsibilities. I, for example, have people that still are working inside of secure facilities because the nature of the work requires it.
Well, thank you. Do you have any concerns, Mr. Jones, about Huawei technology in home internet networks?
Well, I think one of the aspects that we really look at is how do you layer multiple levels of cybersecurity in, because from my perspective, every piece of technology has some level of vulnerability. And so we really look to offset if one product doesn't work the way you expect, how do you layer it on? So for example, like I used the example of I have my work device here connecting over VPN. We use encryption to protect the confidentiality of the work that's being done. We use the hardened operating system that we've done. So we've turned off a lot of features. I can't install different software. I can't bypass our security controls, for example, so that even if, for example, somebody managed to, in the old terms, put the alligator clips on the lines, they can't read anything that I'm doing because the encryption is protecting it. So it's about layering security so that you're not dependent on just one thing to protect yourself.
Thank you for that. This is a question for Chief Superintendent Mark Flynn of the RCMP. This wasn't discussed here today, but I am certainly curious about this. Now, the RCMP is responsible for enforcing quarantines, and we understand that compliance rates are left much to be desired, as many have thumbed their nose at the requirement to isolate for 14 days. So can you explain how you enforce the quarantines, and more importantly, how you deal with non-compliant travelers like U.S. travelers claiming they are going to Alaska through Canada and take other alternative routes in Canada?
Hey, thank you for the question. I am from the RCMP, but unfortunately that's not an area of my responsibility. However, I can say that the RCMP, being both federal policing and provincial police for many of the provinces across the country, has been actively involved in significant efforts to enforce the Quarantine Act, and I'd be happy to go back to my colleagues to get some additional information for the committee.
Thank you, Mr. Weber.
Fantastic. Oh, that's all. Thank you.
Mr. Kellaway,
Mr. Chair, can I just ask that information be provided through you, Mr. Chair, to the committee?
Yes, absolutely. The witnesses,
thank you.
Please take note that any information you want to send to the committee, if you send it to the clerk, it'll be translated as appropriate and distributed. So now we go to Mr. Kellaway. Mr. Kellaway, please go ahead. 4 minutes.
Okay. Thanks, Mr. Chair, and colleagues, staff, and witnesses. Thanks for being here today. My questions will be for Stats Can. So I'd like to start talking about Canadians and mental health through this pandemic. And we know that there are many factors through COVID-19, the pandemic, like job loss and isolation and uncertainty and anxiety, that can impact the mental health of individuals. So can you describe the impact that COVID-19 has had on the self-perceived mental health of Canadians?
Thank you very much for the question. I'll start with one short answer and then turn it to my colleague Karen Mahorian for more detailed if she has some. The one point we were making is that we have seen a significant decline in self-reported mental health during the pandemic. I highlighted in my remarks that youth, for 64% of youth, which is a significant number, have reported declines in their mental health status, and 35% of seniors. And so it is obviously an important issue. Karen, did you have any additional information you'd like to provide?
Yes, thank you. So what we found, not just youth have had a significant impact on their mental health. So what we've been able to compare through our crowdsourcing and our web panel surveys is we compare those data to the Canadian Community Health Survey. So when you look at overall rates of general perceptions of mental health, what people were reporting in 2018, 2019, and then how it compares now. But not just youth are we seeing a decline. We're also seeing it amongst the Indigenous population and as well as immigrants. So these are also populations that have been particularly hit when you're looking at job loss, for example, the ability to financially remain stable. So we are seeing rather significant declines in self-perceived mental health amongst those three groups especially.
Yeah, the numbers on any one of those groups is staggering to me. The 60% with respect to youth is quite striking. With respect to the self-perceived mental health, the report on it rather, are there any policy recommendations that come from it? I know you just mentioned some key findings, which is essential and important, but are there any policy recommendations that you can share with us that you could share with the committee and to the rest of us?
Thank you for that question, Mr. Chair. So Statistics Canada doesn't make policy recommendations. We provide the information for our colleagues, for instance, at BAC, Health Canada, and associations across the country so that they see these data to see, given the impact and that the more severe impact of COVID on certain groups' mental health, that they come up with the policies that are best placed to address that going forward.
Okay, wonderful. Mr. Chair, how much time do I have?
You have 1 minute.
Oh, wonderful. In terms of cyber attacks, I'd like to turn it over to Mr. Jones. We know that cyber attacks on health and research organizations can come from many different actors throughout the globe. In the case of a state-sponsored attack, for example, what plan is in place, rather, at Public Safety Canada or the RCMP or both to put an end to the attack, to find the guilty party, and then to prevent further attacks?
So typically, if there is an attempt to compromise a health organization, we would respond from the Cyber Center. And one of where we've done a few different things. The first is alerts. So when we see anything that a health organization needs to take action on, we issue those alerts, and they're timely. It's either alerts, flashes, etc. And those are things that need to be actioned immediately. Unfortunately, what we've seen is some of those aren't acted upon, and that's leaving vulnerabilities open, essentially making it free to compromise organizations. The second things we do is we actually have a multiple times a week call with all of the health sector around Canada to continue to provide advice on what they're seeing, what we're seeing in terms of targeting, so they can also share back. It's very important that this is two directions, that when they see something that's suspicious, that they report it to both ourselves and the RCMP in the events of criminal matters, although we do share, and that we continue to share. And then the third thing is we actually published a threat assessment specifically to the health sector, the threat bulletin, to say you will expect to see increased state-sponsored targeting as states look to gain more information, for example, on vaccine production, on research, etc., to warn them what it would look like, and then to continue to try to build awareness, because at the end of the day, prevention is far cheaper than responding to any incident.
Thank you, Mr. Kellaway.
Thank you.
We go now to Mr. General. Mr. General, please go ahead. 4 minutes.
Thank you, Mr. Chair, and thank you to the witnesses for being here today on a busy July day. I just want to follow up with Ms. Morris quickly, if I can, with regards to a question from my colleague, Mr. Davies. He asked about the information on ventilators and hospital beds. Just curious as to when you started collecting that information. Was that before January?
So we have some baseline data, particularly on hospital beds and ICU beds. And more recently, I would say over the last few months, we have been collecting information from provinces and territories on that. So we have both historical baseline data and more up-to-date information.
So some of the up-to-date stuff, approximately when did that change that you started collecting more of that?
That's in the last several weeks.
Several weeks, okay. Thank you. Do want to ask Statistics Canada. It's my understanding that you guys are developing a national household survey on COVID-19. Is that's correct?
I don't think, no, we don't have a national household survey, but I can let Karen speak to a few of the surveys that we are launching in the area if you'd like.
Thank you for that question, Mr. Chair. So as we've already mentioned and Jeff mentioned in the opening remarks, so we did develop a web panel where we're following about 7,000 Canadians. These are labor force rotate out, so they've participated in our labor force survey. So this is what we call our probabilistic sample, where we can generalize to the general population. We launch a new topic on a web panel, so it is a household survey. It's done through electronic questionnaire, so they are provided with a link to respond to the questions. So about every 4 to 5 weeks, we send a different theme, and all of these themes have been specifically related on various things related to COVID. So job loss, behaviors that they were taking to protect themselves. As we mentioned before, mental health. We've asked questions around recovery and those sorts of things. Then we also have our crowdsource, which is not a household survey. We are currently working with Public Health Agency Canada on a survey of about 25 to 30 questions, where we are looking at sort of the unintended consequences of COVID. We're hoping to launch that survey sometime later in August. And that will be, again, a probabilistic survey where we'll be able to generalize to the population. So we'll have at least national, provincial, territorial estimates, and hopefully for larger CMAs as well. I'm sorry, I don't have exactly the sample size of that survey.
It would be great if perhaps we have you back and explain some of the data that you get from that. I think that would be interesting. Last question, Mr. Chair, just back to Kai-Hai, is we've seen that the data is obviously lacking throughout in the lead up to COVID-19. What recommendations do you have to improve our data sharing regarding COVID-19, but any future pandemic or a second wave that we could see?
Mm-hmm. I think creating the infrastructure to have more timely hospital data would be a critical piece to support public health surveillance. The hospital data is very rich, and it's a fabulous resource for both health system managers and researchers to follow patients over a long course of time. The piece that's missing in it is the quick, timely information on admission, so that public health knows as soon as a patient is hospitalized, they have that information. It's been challenging with COVID because people often have very long lengths of stay. So getting the information when the patient has left the hospital delays things for up to a month.
Thank you, Mr. General. We go now to Dr. Jaczek. Dr. Jaczek, please go ahead, 4 minutes.
Thank you very much. And my questions will be directed to Kai-Hai and Stats Can. As a number of my colleagues on this committee have said, the testimony from witnesses overall has been extremely critical of our existing data sets that we have, the timeliness and so on. And I'm sure you're very aware of that. So Ms. Morris, you have obviously told us that Public Health Agency of Canada, StatsCan, and Kai-Hai have very clearly articulated areas of responsibility for which they collect data. Mr. Latimer has made the comment that, in fact, there is really no identifier that links across these organizations so that a researcher can follow the data on a particular individual with non-nominal data, obviously, and yet they cannot link across easily. You've made a reference to shared data sharing agreements. Can you explain how a researcher might use those data sharing agreements to facilitate an inquiry? Our witnesses earlier today made it very clear that in the United States, there was a very easy way of following data sets and linking them. What do you see going forward? What exists now, and how can we improve?
Thank you very much for the question. Researchers are a big customer of Kai-Hai's. I spoke of 500 data requests. Many of those were from researchers looking for information to do modeling work to help predict both the impacts of the pandemic on the health system, as well as model restarts in terms of beginning elective surgery and other procedures as things started to improve. One of the things that's particularly helpful with the CIHI data is that it does come with an identifier. So we can follow patients across data sets, whether they be in long-term care, the prescription drugs they've been prescribed, in hospital settings, or in some cases in primary care. We can follow them across. That's particularly helpful at looking at health system performance measures like readmissions or repeat emergency department visits. And it's very helpful at following the complications that might happen over time. So for example, with COVID, it would be very interesting to know for patients who test positive, whether there are actually any long-term health consequences that we could follow over the course of their lifetime. But you're correct that there are data gaps, and some of them really relate to the timeliness of the data. So the data that CIHI collects has been built to facilitate benchmarking across long-term care facilities, hospitals, health regions, and the benchmarking supports improved health system performance. So the data is it's complete, it's comparable, it uses common standards, and it provides very good information on care. But if you think of things like readmissions or pain levels in long-term care or worsening pressure ulcers, these are all things that don't change from day to day typically. And the improvement efforts are okay if you can provide that information on a quarterly basis or an annual basis.
So, Ms. Morris, can PHAC use that identifier to link with their data set?
Sorry, Dr. Jaczek, your time's up.
Could I have
the CIHI data could be linked to testing data because I believe both of them have a unique identifier.
Thank you.
You're on mute.
Nous allons à ce moment.
Now, Mr. Desilets, go ahead. 2 minutes. Thank you, Mr. Chair. First question from Mr. Flynn. We heard tell of the situation with the doctor and his spouse and a group of students who were expelled from the Winnipeg laboratory. What was the RCMP involvement in this intervention?
The RCMP can confirm they've had referrals with respect to activity at the Winnipeg lab. However, it would be inappropriate and could potentially impact an investigation if I were to speak to it with any detail here this morning or this afternoon.
I understand the situation very well. Could we find out, is this a situation that would be considered by Canada as espionage?
As I stated, for me to speak at any level with respect to the investigation could jeopardize that situation.
Perfect.
Okay, I understand. I fully understand. No problem. What type of lessons can be learned? Is Canada too open to receive foreign researchers integrating the teams, or is this a simple filtration error, if you will, somebody that's infiltrated?
So in a general sense, without speaking about this incident, if you look at the history of crime, we have all types of individuals, both Canadians, immigrants, and foreign individuals that are involved in significant crime in Canada. So it's difficult to speak in generalities around this type of situation.
Thank you. Thank you.
We now go to Mr. Davies. Mr. Davies, please go ahead. 2 minutes.
Thank you, Mr. Latimer. At his appearance before this committee on April 14th, Dr. Amir Ataran said the following: scientists need transparent data on the disease from every province to make mathematically and medically accurate disease models and forecasts. We're not there because the provinces hold the data and sharing it with the Public Health Agency of Canada is optional. They have no legal obligation to share. Then, even more foolishly, the Public Health Agency of Canada censors the data before it's disclosed to scientists through Statistics Canada, probably to avoid embarrassing certain provinces, end quote. Can you confirm if PHAC has engaged in the practice of removing information from the provincial and territorial COVID-19 data disclosed to scientists through Statistics Canada?
I can confirm. I cannot confirm or explain or comment on that. I have no idea as to what Public Health Agency of Canada is doing. What I can tell you, it's highly unlikely, and the data they're sharing with us, the only thing we're doing is cleaning it for accuracy. We're not removing or hiding any of the data that we put on our website.
Okay, thank you. And Mr. Jones, if I could, I'm sorry, I just want to be clear on this. Can you confirm if there have been any successful cyber breaches at Canadian research institutions working on COVID-19?
Yes, we have had successful breaches, Mr. Chair, and I think one of the what we have done is we've been looking to continue to reinforce other research institutions, including proactive advice and guidance. One of the challenges I think that's mostly unknown is that research institutions tend to be what we would call more of a small and medium organization. And so we'd also refer them to not only the specific health sector guidance, but the pragmatic steps that we've given for small and medium organizations and advice and guidance as well for them to take a look at.
Can you confirm whether any of those were state-sponsored?
Thank you. Your 2 minutes is up. Oh. And we are running short of time. We're up against a hard cap. So I'd like to thank all the witnesses once again for being here and for sharing with us your time and your expertise, and we appreciate it. It will help our study a great deal. And thank you to the members. And with that, we will adjourn. Thank you very much.